Roadcaster?
Nope, mistake was on my part.
Okay. The receiver wasn't on?
Nope, I had forgotten to unmute.
Oh, okay. All right. So are we good?
Yes, ma'am.
We have sound. Awesome. Okay. So you did the test on page 182 and 183 and then graded them. If you did not get to it, no problem. Just tell me pass when I call your name. Just remember, the further we go, the harder it's going to be to get caught up. Okay. So when I call your name, if you can tell me your scores or how many you missed. Kayla. Felicity. Jamie.
100.
For both?
Yes.
Thank you. Peyton.
80 and 85.
Thank you. Gloria.
85 and 100.
Kenley.
100 and 100.
Thank you. Zarina. Melissa.
95 for both.
Is that me? Nancy.
90 and 100.
Thank you. Jasmine.
100 and 90.
Thank you. Jose. Alani.
95 for both.
Amelia.
Pass.
Isabella.
100 for both.
Do you have one for me by any chance, Isabella? Thank you. All right. Does anybody have any questions on what you missed? Anything, if you missed it and you don't know why the right answer is right or why your answer was wrong? Anybody? Nothing? All right. Tomorrow is our next game show. So I'm going to have 15 test-like questions. You can kind of see how the questions are going to be structured for the state exam, and they're different than what you're doing for homework questions. So there's two parts to learning. Most people don't really know this. There's two parts to learning. The first part is you have to gather and store information. Okay, so that's kind of memorization. That's your homework, right? You're reading it, and then you're answering some questions to see, hey, did you gather that information and did you store it? Okay, so it's what we call concrete questions, like, is the sky blue? Okay. The second part to learning, though, is probably way more important, and that's application. So just gathering the information doesn't do you any good if you can't utilize it. So the questions on the state exam are going to be application type questions. So they're more scenario based. They're going to say, what are you going to do when? Make sense? And you've got to use the knowledge that you have to be able to answer the question that is asking you to apply that knowledge. So the questions that you have for your homework are just trying to find out, did you get the knowledge? The practice test is going to help you learn how to apply the knowledge. Now, the game show that I do on Tuesdays, it's the first and third Tuesday of each month. That game show is not graded. It's not part of the class. I'm not going to check to see if you attended, nothing like that. But it probably would be worth your time to either participate or at the very least go back and review it so you can kind of see the types of questions that you would have on the state exam. Now, as we get toward the end of the program, I've got two practice test opportunities for you. We'll talk about those toward the end. I don't want you to try to take them now. I'm not done with you yet. Okay. A lot of people try to race to that practice test to prove to themselves that they have the knowledge, and you're still coming to class. So let me do what I need to do, and then we'll let you test yourself. Good? Good. All right. So quick review. How do we know what to do with each patient? Care plan. We follow the care plan, the whole care plan, and nothing but that care plan. So we don't change it, alter it. We follow it exactly the way it is. While we're following that care plan, doing those tasks, what should we also be doing? Yeah, observations. So what do you need to kind of pick up about this patient? What has changed? What's different? And then what do we do with those observations? Report them to the nurse. That's right. So we now know how or what to do with each patient. My words are all mixed up today. We now know what to do with each patient. We're going to follow the care plan. We don't make it up as we go. But once we know what to do, now we got to figure out how to do it. And that's where the rest of the principles are going to come in. The rest of the principles are going to tell us how to do those tasks. So every skill is going to start with the opening. Universal. Every skill starts with the opening. I don't care what skill you're doing, you have to do the opening. And every opening starts with a knock. Absolutely. So on the state exam, when your brain has fled, Elvis has left the building, and that will happen when you're testing because you're nervous and now it's go time and your brain is likely to freeze. You have to have a well-defined starting point. So knocking is our well-defined starting point. Once you knock, you can kind of roll into the rest of it's kind of like your body relaxes. Okay, I know what to do from here. Okay. So every skill starts with an opening. Every opening starts with a knock. Once you've entered the room, remember for the test, you don't have to wait for a come in. It's fine. Just go in, but you've knocked. Once you've entered the room, we have to greet the patient. And we're going to be nice about this. Good morning, good afternoon, whatever. And we're going to address them by name. We're not going to say honey, sweetie, dear, lovey, nothing like that. We're going to address them by name. And if they're not that person, they'll let us know. Okay, that's our way of identifying for the test. But remember, in a clinical setting, we also have to go by our policies and procedures. And wherever you work in a clinical setting may actually have you check an ID band. We go by the policies and procedures wherever we're working. But the policy and procedure for the test is to address them by name. Once we've done that, what do they need to know about us? Our name and title. Good morning, Miss Jones. My name is Pat, or how are you today? My name is Patty, and I'm your CNA today. Good. Once we've got the introductions out of the way, what do they need to know about why we're there? What we're going to do. So you can say this any way you want to. I'm here to, I don't know. Yeah, you can say it any way you want to, right? Put it in your own words. Or if you're nervous, you can read it right off the care plan. Good. We're going to do that because we need to get something from them. What do we need to have from them? Consent, permission. Do patients have the right to say no? Yes. What do we do if they say no? Tell the nurse. Hands off. Try to find out why, because the nurse is going to ask you why. So try to find out why nicely. But we're going to accept their no. Okay. This actually just came up in one of the Facebook groups I'm in. Somebody got on there and asked, what do you guys do with patients that consistently refuse showers? And that's very common. We're going to talk about that. Well, what do you do when a patient consistently refuses a shower? And it absolutely appalled me how many current CNAs that are out there working said, well, I bathe them anyway. That is assault and battery. And you can be held criminally liable for that. We have to be super careful here. Just because somebody is in our facility does not mean that we get to decide what's happening with their bodies. So I want to talk just a minute. Let me get through this, and then we're going to break for a second. I want to talk for a minute about the patient experience, especially with dementia. So let me finish this up, and then we're going to switch gears just a little bit before we get to the rest of these, because this is kind of important. So we're going to obtain consent, and then we're going to close. Is that curtain clean? No. So what do we want to do after we touch a curtain? wash our hands. And then now that we have clean hands, we can go get our clean supplies. Good. Our cardinal rule here is that we don't touch the patient until our hands are clean. All right. So let me give you kind of a visual or a imagination example. Okay. So we're going to kind of use our imagination here. So you guys all speak English. You're in America. You've been here. You're comfortable here. This is home. Everything's pretty much normal, right? But imagine tomorrow morning, you wake up and nothing looks familiar. You're in a completely strange place. The walls don't look familiar. It's not your bed. Those aren't your clothes. Nothing is familiar. And then some stranger walks in that you've never seen before in your life. And they start talking to you, but it's not English. How afraid are you going to be?
Very.
Depends if I have my money on me.
Okay, you don't have any money. In fact, you aren't even dressed.
Could've been a good night, but
Yeah, probably that's not where your mind is going to go. Okay. Or it could be where your mind goes, but you're not on the right end of that equation. Does that make sense? You guys understand that? This is what it's like to wake up with dementia every day. You're in a strange place, a place you do not recognize. You are surrounded by strangers, people you don't know. You are not fully dressed because you just woke up. And then some stranger who you don't know, who's talking to you in a language that you don't understand, puts their hands on you. What are you likely to do?
Get agitated.
Oh, I'm hitting first and asking questions later. Absolutely. Because right now, my threat level has elevated to DEFCON 1. Okay, we're going nuclear. Because I don't know who you are, and I don't know what your plans are for me, and I am not dressed for any of it. And I am afraid because my people are not here, and there is nobody to keep me safe. And you are a threat. This is why dementia patients react, because that's their reality. Now, we are used to being there, right? That's our work. It's just another day at the office. I've got to get you cleaned up, Miss Jones. You know, we kind of go through the motions, but we often don't stop to think about what this is like on the other side of that equation. We know who we are. We know who they are. We know where we are. And thank God for all of that. But your patient doesn't have those same faculties. If they did, would they be there? Where would they be? At home. Absolutely. So the very fact that our patients are not at home, that they have to rely on us for things, means that there is a deficiency. Could be mental, could be physical. In most cases, it's both. And we have to keep that in mind. And that is why our opening is so important, because it can help ground the patient. If this is done by every single person, every time they walk in the patient's room, every time, that's consistency. And consistency de-escalates threat. Do you guys understand why this is important? It's easy to get lost in our day-to-day. But sometimes we have to stop, back up, and think about this from their side of the bed. Don't skimp on this. A lot of people think, well, I just have to do this for the test, and that's all I have to worry about. And that couldn't be further from the truth. In fact, the test, really, I don't care about. I don't care about the test. I care about that little old lady that you're going to walk into one day who is scared to death. And if you don't do this, if she doesn't know what you're about, you could potentially kill her out of fear. Good? Okay. This is way more important than people think. All right. So now that we've done our opening and we've gotten permission and we've acclimated the patient to why we're there, now we've got to start thinking about our supplies. We've washed our hands. We're going to go get our supplies. And one of the supplies that we might need are gloves. It's a possibility. Maybe we'll need some gloves. Okay. Now, we're not just going to wear gloves all the time for everything, because when we do, we stop paying attention to what we touch with those gloves, and that's going to put everybody at risk. It's going to put them at risk. It's going to put us at risk. It is not doing what you think it's doing. Why are you wearing the gloves if it's not helping either party? So we've got to get a little more strategic with this. So we're going to wear gloves if we could possibly touch body fluids, personal skin, and non-intact skin. Okay. Body fluids, personal skin, and non-intact skin. So we had a question not too long ago that was, if I'm changing sheet, or what, why weren't you wearing gloves when you change sheets? If I'm changing sheets, dirty sheets, I want gloves on. And the answer to that is, well, it depends. If our patient is fully dressed in bed, fully dressed, if there are no body fluids anywhere, do I need gloves? No, because I'm not touching any of the patient's doorways, and their fluids aren't touching my skin. Now, if I'm working with a patient who is incontinent, she's leaking urine. Now there's body fluids. Do I need gloves?
Yes.
Yes. But I got to pay attention to when I put them on. We're going to put our gloves on right before we touch the patient. So the very first thing our gloves should touch is the patient, and that keeps our gloves clean for the patient. Once I've touched that patient, now my gloves are soiled. I've got to pay attention to what I'm touching in the environment. Do I want to touch that curtain with soiled gloves? Call light, sheet, bed controller, food tray, water cup? No. Once the gloves are soiled, they can only touch soiled things. Good? And then we have to know how to remove them. And then we have to remove them correctly. Okay? To remove gloves correctly, we're going to pinch up at the cuff, pull that off, wrap it up, go underneath, pull that off, and throw away. This helps prevent cross-contamination. Okay? So the first thing we're going to think about when we're talking about supplies is, do I need gloves for this? The answer is not yes to everything. And if you try to wear gloves for the test for every skill, they're actually going to stop you and say, you don't need gloves for this. And you will get a deficiency in infection control. And you should, because you don't understand it yet. Okay? Go back and rewatch. All right, if we need supplies, we've got to have a place to put them, and this table is not clean. So we need a barrier, which we're going to use a Chucks for the test because it's absorbent and waterproof, but we need a barrier to put on the table, and that barrier is going to provide a clean area or a clean place for our clean supplies to lay until we use them. We can only touch supplies with what kind of hands? Clean hands. So should we go get our supplies and then walk into the room?
No.
No. You might actually see people during the test do that. It's a possibility. The person that you're testing with will probably not be somebody from this class. And there are a lot of places out there that teach their students to go get their supplies and then do the opening. Now they might actually pass. Remember I said that there's always more than one way to do a skill? They might actually pass. But is that the right way to approach a patient if we're asking consent? No, we have to think about the impact of that on the patient. And while it might be enough to pass the test, it doesn't necessarily mean that they're going to be a good CNA. Good? Remember that you don't have to get 100% to be a CNA. A joke that we used to use years ago is, how many guys have a doctor that you see? Doctor. Have you ever asked your doctor, hey, where were you in your class rankings? Because there's only one top spot, right? There's only one top spot. So if somebody says that they graduated top of their class, they are the only one that got that top spot. Everybody else was under them. Make sense? Okay, only one top spot. If you come in first place, only one person can come in first. Everybody else is below that. Have you ever stopped to think about where your doctor ended up in those rankings? Now you're getting a little creeped out, right? Well, wait a minute, hold on. I want the top guy to treat me. What do you think your patients want? The top, that's right. Do you think they want somebody who just barely scraped by the test, got a 70 and, barely scraped by the skin of their teeth? They're not going to ask, hey, what did you score? But maybe they should. Maybe they should. But here's something for thought. D's are still a passing grade, right? D's are still a passing grade. What do you call a doctor who graduated from medical school with straight D's? Doctor. That is correct. You still call him doctor because he still graduated. It's important. Even though you may see somebody do something different, those are those D students. They might actually be practicing, good for them, but we can be so much better than that. Make sense? All right. Well, if we're going to get supplies, do we want to hold those supplies up next to our uniform? Why? Your uniform is not clean once you start working. That is correct. So in order to prevent us from holding things against our uniform, we're going to get the barrier first, put it on the table, go get our supplies, and put those on the barrier. Everybody understand why? All right. One of the supplies that we might want to consider getting is a privacy blanket. Now, no care plan is going to tell you a privacy blanket is required for this skill, right? They're just not going to tell you. Remember, all the principles are things you need to know. They won't be on the care plan. You guys remember that? Right? So no nurse in the history of ever is going to say, change patient sheets and use a privacy blanket. They're not going to say that. They assume that you will know when a privacy blanket is indicated. So when is a privacy blanket indicated? Well, we have to think about why we're using it. We're using a privacy blanket for two reasons. The first is privacy. It's right there in the name, right? Privacy blanket. We're using it to cover the patient. But it's not just for privacy. It's also for warmth. Remember, facilities are going to feel cold to your patient. We're up running around, fully dressed. It's going to feel warm to us. Like me up here, okay? But that patient is going to have a totally different perception of temperature. If you take that sheet away from them, now they're really cold. So not only do they feel exposed, there's that privacy part, but now they feel cold. Are they uncomfortable?
Yes.
Yeah. So we want to make sure that we're using something, if we're taking their sheet away, that we're using something to keep them comfortable. Good? So privacy blankets are going to be used anytime our patient is uncovered or undressed. And the short way to remember this is Miss Patty should never see knobby knees. If you can see their knees, you took a wrong turn. Good? I know I've been saying that for a long time. I use these little sayings, and they're worming their way into your brain. You probably don't realize it, but they're worming their way into your brain. And I had a student not too long ago that came to me, actually came back and told me, thank God for your knobby knees. And I said, what happened? She said, I was testing, totally forgot about a privacy blanket. I looked down and saw her knees. I saw her knees. And it triggered. I should not be seeing knees. Something is wrong. And she went and got a privacy blanket and she scored 100%. Okay. So these little sayings, I know they sound all wacky, right? They're designed to have an impact. They're designed for you to remember them. All right. We're going to put the blanket on top of the sheet and pull it down so we never, ever, ever see their knees. And when we put that blanket on, we don't want to snap it or shake it because you don't want to bring up all of those skin cells, yeast, bacteria up in a vortex where you can breathe it right in. We do this at home, don't we? We just snap that sheet out, right? If you put talcum powder on your bed before you snap that sheet, you can actually see this happen. Now, these yeast and skin cells, those are way smaller than talcum powder. So if you're able to pull up talcum powder, you can absolutely think about all the other stuff that's in the air with it.
Are you saying we don't put the blanket underneath the sheet?
Nope, put it right on top of the
Right on
sheet,
top of it.
pull the sheet down
Pull the
underneath.
sheet down and the privacy blanket
Stays.
goes up. Okay.
Yep. Good? Good. All right. We're going to remove the blanket at the end of the skill. If we use one, we're going to remove it at the end of the skill after we remove our gloves. After we remove our gloves. You don't want to touch that sheet that's going to go right up next to their face with gloves on. Good?
What if we're not wearing gloves?
Then it's fine.
Okay.
But don't touch the sheet with soiled. So here's why. I'm going to back up real quick. Here's why. We wear gloves if we're going to touch body fluids, personal skin, butt juice, guys, or non-intact skin, doorways, places that things can get out, right? So we're wearing gloves because we think we're going to come into contact with a pathogen. We're not wearing them for everything. We wear them when we think we're going to come into contact with a pathogen. So if you've got gloves on, that means you were in the danger zone. Do you want those danger zone gloves to touch the sheet? Does that make sense?
Yeah.
Okay. You have to think about when you're going to wear gloves. If we're wearing gloves, we got some kind of juice. All right, so linen rules. These are all repeats of things we've already learned. That means they're doubly important. Linens cannot touch your uniform. You have to have clean hands to get your clean linens. We're not going to snap or shake those linens, right? We don't want to bring up any sort of pathogens into our breathing space. Now we're going to skip a couple. We're going to come back to these a little bit later. And we're going to go down to the very bottom. Unused items must be discarded. So we use it or we lose it. We don't leave it in the room till later because anything that's out of your sight, we don't know what happened to it. Somebody may have sat on it and farted on it. I don't know. But I'm not going to trust it on my patient's eyeballs. Good? All right. So we're going to come back to those two in just a little bit. And then the closing is at the end of every single skill we do. It's always the same. Your patient must be in a clean and safe environment. So take a look around, make sure everything is all cleaned up. And by that, for the test, because the environment's always clean, it's a test, right? Everything is, the patient's only in bed for like 3 minutes, right? The environment's always clean. What you want to pay attention to is this right here. This is the part that's probably not clean because you left the barrier on it. You left the dirty washcloths on it. Okay, so look at the table when we're talking about clean and safe at the end of the skill. Bed should always be in what position? Low position, absolutely. We're going to ask about comfort. They need to hear that word, comfortable. Are you comfortable? And we're going to offer a magazine or something for emotional comfort as well. This is what we call addressing preferences. Okay. If the patient wants the head of the bed up at the end of the skill, that's fine. Whatever's comfortable for them. I don't care. If they want the curtain closed, that's fine. Whatever's comfortable for them. I don't care. If they want the TV on, that's fine. Whatever's comfortable for them. I don't care. But if it's something that makes you go, huh, that's different. What do we do with that?
Tell the nurse.
Tell the nurse. That's right. That's right. We want to make sure at the end of the skill that they are covered. Clothes or sheets, I don't care. Should I see those knees?
No.
Nope. And we're going to open the privacy curtain at the end of every skill because people are social creatures. Not always. There are some days that I hibernate in my little home office and I close the door because I don't want to be disturbed and I am not feeling particularly social today. And that's okay. We're all humans. We have those days, but that's an observation. And what do we do with that? Tell the nurse. The nurse may go, that's fine. I don't care. And other days, the nurse will go, I think I probably ought to go in and talk to the person. Let's see what's going on. Because your nurses know their patients. They know what medications predispose them to depression. They know that they just got the lab work back and that cancer is no longer in remission. They know the patients. What they need is the information that you have locked in your brain. Good? Good. We're going to give the patient their call light. I usually tell them how to use it. They're medicated. They're sleep deprived. They got a lot going on. So I usually say, press the red button if you need me. Give them instructions. Perfectly okay. Reminds them. It also kind of lets them know that I care. If I just throw the call light on the bed and go, you need me, they're probably not going to feel very secure about calling me, are they? They're going to feel like they're interrupting something or they're a nuisance. If I hand them the call light and say, if you have any needs, just let me know. Just use that red button and I'll be right back in. That is an invitation. Those two things, even though I still gave them the call light, are going to be perceived differently by the patients. Okay. Once we've got all of those things done, I don't care what order you do all those things. I do not care. Clean and safe environment, covered. Are you comfortable? Would you like a magazine? Here's your call light. Open the curtain. I don't care how you do all that stuff, whatever order you want to do it in. But my advice to you is to pick a specific order, memorize it, and just keep doing that over and over. Okay? Pick an order, memorize it, and do it. That way you never forget something. Once you do all that, though, you're going to go clean your hands. What we're doing here is cleaning off the patient's cooties. They're comfortable with their cooties. They've been living together a long time. Everything is good. It's like an old marriage. Everything is fine, right? They're fine with their own cooties. But they are not fine if I bring somebody else's cooties to them. So I'm going to wash my hands before I touch them. So I'm not bringing anybody else's cooties for the ride. And at the end of the skill, I'm going to wash my hands after I've completed my skill, so I'm not taking their cooties to the next patient. Good. So we're going to wash our hands here. And once you wash your hands, don't go back and give the patient a call light. If you wash your hands and come back over here and give them a call light, what'd you do? You re-cootied up. You are now cootie central again. And that's the whole point of this, right? All right, so once we wash our hands, we can document. If we document, we're going to wash our hands again because our cardinal rule is to end skill with clean hands. I don't know what cooties you got on that pen. I don't know where that pen has been, but it's probably been in the bathroom with you. You don't empty your pockets when you go to the bathroom, do you? You don't know what's on that pen. So once we use it, we're going to wash our hands again.
Do we actually have to wash our hands, or we can just be like?
So for the test, great question. For the test, let's talk about the test right now, okay? Because in real life, yes, you have to wash your hands. But let's talk about the test. So for the test, you're going to get your care plan set. I am going to trip on that. I know I will one day. You're going to get your care plan set. It's going to give you 3 skills to perform. So give me a number 1 to 11. 7. So the computer picked skill set 7 for you. These are your 3 skills. Ready? You're going to feed a resident who's in a chair. You're going to provide hand and nail care, and you're going to ambulate a resident using a gait belt. Oh, I like that skill set. Okay. So those are your 3 skills. You got to do them in order, and you need a patient to do them on because you can't feed a mannequin. So you're going to be her patient. Okay. So you're going to feed her. You're really going to get fed. For real. It's pudding or applesauce, but she's actually going to put food into your mouth. Do you want her to wash her hands before she does that? Yeah, I would think you would, right? So for the first skill, you are absolutely for real going to go wash hands. And at the end of the skill, you touched her cooties. So you are for real going to go to the sink and wash your hands for real. Now, the other 2, provide hand and nail care. Yeah, you don't have any openings on your hands. No need, right? So we can simulate hand washing. The last skill is ambulate with a gait belt. Yeah, you're not around any body openings, so we can simulate hand washing. So for the, do you guys remember I told you on day 1 that this is extremely scientific? That there is nothing to chance here, right? So your first skill for every single one of these care plan sets, your first skill, you really have to go to the sink and wash your hands before and after you perform the skill for real. But after that, the evaluator is going to tell you you can simulate hand washing from this point. So simulate just means say. You would go, hi, Ms. Jones. My name is Patty. I'm your CNA today. I'm here to do hand and nail care. Is that okay? Close curtain. I would wash my hands now. Let me go get my supplies. So you're just verbal placeholder. You don't have to go to the sink. Good. So in each one of these skill sets, if we are doing a skill on a live person that puts us anywhere near any of their body openings, body fluids, non-intact skin, it will always be listed first on our care plan. That keeps both you and them safe. Good. Make sense? Great question. Any other questions on that?
So we should go in and do our opening and then go wash our hands, or do we just go in and wash our hands and then say hello? Which way do we do that?
Okay, so let's go back here. Let's go back here. Read that. Where are we washing our hands?
Right. At the end.
At the end. That's correct.
So on the test, you couldn't go in and wash your hands and then address them. Like if the sink is over here and your patient's all the way on the other side.
You are invading a patient's space and they have no idea who you are or why you're there. Let's think about that from the patient's point of view for a second. Do you think that's going to raise their anxiety if they don't know who the stranger is in their room that's washing their hands and they don't know why they're there? They know that there is something that person is going to do with them. Otherwise, why would they be washing their hands? But there's a stranger in the room washing their hands, and I don't know who they are or what they have planned. What do you think that's going to do to their overall
Well-being.
Yeah.
It's gonna mess with them.
Okay. That's why this has to be done in this order. Good.
Thank you.
You're welcome. Does that make sense?
Mhm.
All right. So now I have no idea where I was. There we go. Okay. All right. Any questions on the principles we've learned so far? Now we're going to review some of the skills that we've learned. One of the skills we learned on Wednesday was how to measure a radial pulse, how to take a pulse. And a pulse is a measurement of how many times the heart beats over 1 minute. We don't always have to count for 1 minute. How long are we going to count for?
1 minute.
Easy answer. Easy answer. How long are we going to count for?
1 minute.
Easy answer. You guys remember what the easy answer was on day 1? How long are we going to count the pulse? Say it loud.
Depends on what the care plan says.
Whatever the care plan tells us to do. Easy answer. Easy answer. Okay. So when you catch yourself going, well, I wonder, the easy answer is always the care plan. Because if you're answering that question, you may be going against the care plan. Do you guys understand that? So a pulse is a measurement of how many times the heart beats over 1 minute, but how long are we going to count for? Whatever the care plan says. Now, you're right in that you actually jumped a step. Okay, you're right in that the care plan is going to tell us to measure for 60 seconds, 1 full minute. You're absolutely right, but you missed the most critical part of that equation, whatever the care plan says. Because what if that care plan on the test says 15 seconds? What if the care plan on the test says 2 minutes?
You count it for 2 minutes.
Okay. You guys understand that? How important that is? Don't rely on what I'm telling you. Don't rely on me saying the care plan is going to tell you to count for 60 seconds. I'm giving you that shortcut, but that doesn't absolve your responsibility for reading the care plan during the test. Good. I cannot overstress this enough, guys. You have to follow the care plan.
The care plan always specify how long you have to take a pulse?
No, actually, it won't. In most cases, if the care plan does not specify, it's 15 seconds and multiply that by 4. Okay, if the care plan doesn't give us any other, if it just says go take the radial pulse, it's 15 seconds multiplied by 4. If it doesn't say radial pulse, it's the radial is our default. So our default is radial. Our default is 15 seconds multiplied by 4. The care plan for the test is going to give you your location and the time. They're going to give that to you, but our time for the test will be 60 seconds. But in a clinical setting, our default is 15 seconds and multiply that by 4. Some clinical settings, our default is to use a pulse ox, which is way easier. You put a clothespin on their finger, it gives you a number. Nobody's counting anything. Great. Love it. Easy. We always go by our policy and procedure manual for our facility and our care plan for our patient. Good. And every one of those is going to be a little different. Let me give you an example. How many guys want to work in the hospital? Okay. If you work in an emergency room in the hospital, you're going to be using a pulse ox. You'll never take a manual pulse. It's always a pulse ox, the little clothespin thing, always. If you work in a cardiovascular ICU, this is where people have heart caths and they're in recovery, or they've had open heart surgery, you will probably, your policy and procedure will probably indicate that you are to take an apical pulse. Now, if you remember, we talked about that. That's the stethoscope listening to the heart, and it'll tell you how long to count for, which is usually 60 seconds. If you are in a ICU, a neonatal ICU. These are teeny tiny itty bitty preemie babies. Yeah, you can't take a radial pulse on them very well. We generally will use a brachial pulse or an axillary pulse on them. We generally don't use the clothespin for pulse rates. We want a direct measurement. So even in the hospital, so you guys are all working in the same place, but even in the hospital, each unit may have a different policy and procedure based on the patient population of that unit. So we have our policy and procedure that kind of gives us general guidelines. But not all of our patients are going to be exactly the same, are they? So then we have our care plan to further narrow it down for that patient. You guys starting to see how the whole thing is structured? We learned the principles in class. Our policies and procedures tell us which principles for that unit. And our care plan tells us how to adapt them for that patient. Okay. All right. So we're going to support the arm while we're taking it. We don't want that arm held out. Normal is between 60 and 100. And we're going to use our fingertips, not the flat area of our fingers. Which finger can you not use to take a pulse? The thumb. The radial pulse, which is what we're going to use for the test because our care plan told us to, is going to be at the very top of the thumb side of the wrist, not down here, not near the pinky. It's way up here at the top of the thumb side of the wrist. So thumbs, right? The pulse is all about thumbs. Don't use yours, use theirs. Okay. Good? Okay. You're going to say start and stop for the test. When you start counting, when you stop counting. And here I actually did the timing for you. For the test, you're responsible for it. So pick a starting point on the clock and say start. Count what you feel until the second hand goes all the way around to that starting point and then say stop. The evaluator will be on the other side of the patient they're counting to. Hopefully you'll get close to their number and be accurate. But for the test, even if you aren't accurate, let's say the evaluator got 76 and you got 42. Well, one of you is wrong. And I'd be willing to bet it's not the evaluator. So you are way off. 76 and 42. That is way off. You can still pass this test, even being that far off, as long as you did everything correctly. Because for these skills, accuracy does not count as much as technique. Because if you're doing it right, if you're hitting all the steps and you're doing it right, yeah, you'll get more accurate with time. That's okay. But if you're doing it wrong and you keep doing it wrong, are you ever going to get better? No. So it's technique they're grading us on, not accuracy. Good. So this is a documentation skill. Don't forget to document. That's one of the, I'm going to grab this chair. That is one of the most forgotten steps on Pulse is people forget to write it down. And then they get really mad, really mad, really mad. And they get, can I get you to move your bag real quick? They get into my comment section. Oh, thank you. And they write things like, all I forgot to do was write down the pulse and she failed me. She failed me. Let's talk about that. Those evaluators don't fail you. That's right. Those evaluators don't pass you. Those evaluators have nothing to do with your score. Not a thing. They are there to put check marks in a box. That is it. That's it. When they put those missing check marks, those deficiencies into the computer is the one that decides whether you pass or fail. That evaluator had nothing to do with it. Nothing. So first off, that evaluator did not fail you. Your actions determined whether you passed or failed. That evaluator had nothing to do with it. But let's talk about you forgetting to document. Why would that fail? Why could we be 42 and 76 and still pass, but not writing it down failed us? Why would that step be so important that one step could fail us on the state exam? What do you think?
Simply, you need to pass that information to the ROM. Like they're the ones thinking.
Why? Yeah, why? Yeah.
You don't document, it doesn't happen. It doesn't happen.
Okay, so here's the back part of the story that you probably haven't really stopped to think about, right? So if I ask you to take a pulse, I'll just pick on you. I ask you, hey, can you go take a pulse for me? You go take the pulse. You don't write it down. You don't tell me what the pulse was. I ask you to go take a pulse and you do it. Thank you. Why did I ask you to take the pulse? Yeah, say it loud. I need it. It's not busy work. I'm not just trying to give you something to do to get you out of the nurse's station. I need that information probably to give a medication or to evaluate the effectiveness of a medication. I need that information to do my job. So if I ask you to do something and you do it, but you don't give me the information I needed when I asked you to go do that task, did it benefit the patient? No. That is why that step will fail you, because it has a direct impact on the patient. Every step on the test that has a direct impact on the well-being of the patient is a step that can fail you, because the test is not about you. The test will never be about you. That evaluator did not fail you because you forgot to document. That puts everything on you. You think you're the center of the world. That's not what this is. The nurse needed that information. The nurse asked you to go get that information. You got the information, but you didn't pass it on where it needed to go. Therefore, it wasn't done. Not in the nurse's orbit, right? If she doesn't have the information, it's just as good as you didn't do it. Does that make sense? Are you starting to kind of demystify the test a little bit now? It's not about you. Each one of these steps is going to be important to the healthcare system. How well we all together collectively take care of this patient. If you drop the ball, it's going to affect more than just you. And the fact in my comment section that people don't understand that everything they do or don't do as a member of the healthcare team affects more than just them, tells me exactly what kind of CNA they're going to be. Do you guys see that? This is why my students pass. Seriously, this is why my students pass. Because you get it. Oh my gosh, if I don't write this down, the nurse isn't going to get the information, and they need that. So I probably ought to.
Document.
Yeah. There's a consequence if I don't do my job right. Now, all of these steps start to become a little more important. Good? Good. Okay.
I do have a question.
Yes.
About radio.
Yeah.
Radio plus minimum. Anytime you actually do need to do it, you're probably documenting it. Would that be a correct assumption?
Yes. Yes. Generally speaking. Now, I can't give you 100%.
Sure, I'm sure there's something where you just verbalizing is enough.
Absolutely. And particularly in emergency situations. So let's say, I'll give you one. Let's say that we have a patient who is diabetic. They start to get really dizzy. They are pale. They're sweaty. They're off balance. You get them to sit in a chair very quickly. Okay. And you yell down the hallway to a nurse, hey, I need some help here. And guys, by the way, you may have to be vocal. Okay. There should never be a situation in healthcare outside of home care that a caregiver, now I'm not talking about assisted living. Assisted living is like apartment living, congregate meals, laundry. That's not health care. That's personal care. There's a difference, right? I'm talking about healthcare, nursing homes, rehabs, same-day surgery centers, hospitals, that type of health care where there's a team involved. You should never be outside of hearing range of another healthcare worker. You should never. Not in healthcare. I'm not talking about assisted living is different. I'm talking healthcare. You should never be in a place alone with patients where there is nobody that you can yell to for help. If you are, quit. Let me say that again. If you find yourself working in healthcare, and you are placed in a place that you do not have verbal access to another healthcare worker, you cannot scream for help. That is not a safe place for you to work. You guys understand that? There are a lot of CEOs out there that think that their bonuses are way more important than safe staffing. And they have no problem putting you on the chopping block. Doesn't affect their bonus one way or another if you die. They don't care. I wish I could tell you that healthcare was what we all envision it. This is the reality of healthcare. If enough people make enough waves, they'll fix the issue. Okay? We don't have that problem here locally, thankfully. I haven't heard of any issues here locally. That doesn't mean it can't happen. So if you find yourself working in a place where you cannot yell for help and get help, quit. Outside of that, you should never be in a situation where you can't yell for a nurse or somebody to go get a nurse. Okay? There's a housekeeper in a room. They are still a staff member. Hey, go get me a nurse. Quick, run. Okay, good. So as a nurse, I'm coming down the hallway and I say, hey, what's their pulse? Quick, what's their pulse? Yeah, just give me a pulse. Let me know. Because there's going to be a big difference between if their pulse is 72 and regular, but they're dizzy, or their pulse is so fast I can't measure it. Big difference. Now, if you give me that information verbally, I can do something with it. I can intervene, right? If you stop and write it down, now my patient isn't getting the care that they need. Even though we are going to document at some point, but 99.9% of the time you take the pulse, you write it down, everything is fine. But there are going to be certain situations where you will have to give a verbal.
Will they, on the exam, will we actually have something physically to write on?
Go to page 168 in your spiral book. These are the exact documentation forms that you will be using on the state exam. So yes, you will be handed a form and a pen before you start the skill. Good?
So we forget to document. That's really like on a, if they hand it to you before the skill, it's not like on the wall, like you don't have to do it. Okay.
Nope. They're going to say, here's your documentation form. Here's a pen. And you get to put it anywhere you want to. So me personally, right here on my overbed table, right where I can see it, in my way. That documentation form is front and center. Because I know the nurse is going to need that information and I've got to remember to write it down. Good?
Okay.
I can't tell you how many CNAs I've had to go chase down hallways. Hey, what were the vital signs? I got to give meds. What were I'll write them down later. No, I need them now. I've got to give meds. Be a good CNA to your nurse, please. All right, dressing a resident with a weak arm. This is just getting them dressed, guys. They have a weak arm, though, so that's going to affect how we dress them. You want to make sure you're not overextending or force movement. We're going to ask them what they want to wear. We'll gather the clothes before we undress them. And because you never want your patient laying there naked. I mean, that just makes sense. So get the clothes, ask them what they want to wear, get everything ready. Then you can get them undressed and start dressing them. Doesn't matter whether you start at the bottom, work your way up, start with the shirt, work your way down. I don't care. Nobody cares. Do it however you want to. Socks go on, make sure the toe seams line up over the toes. Pants go on, make sure they're up over the butt around the waist. Tag in the back, obviously. And then when we get to the shirt, undress strong arm first. That makes it do all the work. Garment just slides off that weak arm. Dress weak arm first. That way the garment just slides up that weak arm. Make sure everything is fastened appropriately. And you don't have to pull the sheet up at the end because they're already dressed. If they want the sheet, that's fine.
Should we wash our hands before the clothes? I mean, after we get the clothes, that's like getting our supplies. Should we wash our hands before and after, or?
So clothing are supplies.
Right.
They're considered part of your supplies. So we have to think about our opening, right? Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to get you dressed. Is that okay? I'm going to close the curtain. What do I do after I close the curtain? Wash my hands. And then I'm going to go get a barrier because I have supplies. I need a place to put them. I'll get a barrier, put them on the table. Now I can go get the clothes, ask her, what do you want to wear today? And put those on the barrier.
Okay, thank you.
Okay. Somebody else have a hand up?
I forgot. So,
Oh,
when I think about
I'm
it-
sorry.
No, you're good. I don't know what happened. So if I think about it again, I'll just.
It's fine. It is Monday.
Yeah, no, literally.
All right. So this is what we have covered so far. Okay. So out of the 11 principles on the back wall, right? Remember that from the first day, all of those colorful principles on the back wall. This is what we have mastered. We know to read the care plan. We know to start every skill exactly the same way. We know to decide if we need gloves. We know to use a barrier if we're going to use supplies. We know how to identify if we need a privacy blanket. And we know how to treat linens if we're going to use them. We know how to end every skill. And if we follow these principles, we are going to get more than half of each skill checked off without even doing the skill part. Okay? More than half of each skill are going to be covered by these principles on the test. Good?
do have a question. About the linens. I don't specifically remember the real policy behind the linens. Like, it's a blanket, yeah.
So linens can be blankets and sheets and clothing and washcloths and towels and anything that we use on the patient that is basically not hard. So supplies would be things like toothbrushes and toothpaste and basins and gait belts, right? Those are supplies. Linens are what kind of the soft stuff that we use on or with patients.
What exactly are we doing with them other than putting them on the patient, or are we changing the bed sheets? Or
So
something?
it depends on the skill.
Okay.
Okay, so these linen rules are going to show up in lots of skills.
Okay.
So let's say, let's talk about mouth care. So mouth care, we're going to need a towel over their chest. That's a linen. Hand and nail care. Well, we're going to wash a hand. So we need washcloths. We're going to rinse a hand. We need a washcloth. And we're going to dry the hand. We need a towel. Foot care. We need some washcloths and towels. Making an occupied bed. We need sheets. Dressing a resident. We need a privacy blanket. So linens are going to show up in a lot of different skills.
That was my mistake. I just didn't associate this skill yet.
Yep, no, and that's not your fault because we've only seen 2 skills so far. So you're right on track.
So they only need the blanket when their knees are exposed, so if they have pants on.
Right, no blanket necessary.
Okay.
Yep, and that's why I say it that way. I don't want to see their knobby knees, right? So it kind of, as long as you're not seeing knees, you're good. So if they've got clothes on, you don't need a blanket. If they've got a sheet on and you're not taking it away, you don't need a blanket. Good? Does that help?
Yeah, thank you.
Anybody else? All right, so let's learn hand and nail care. If you go to page 116 in your book, all right, if you're looking at this page, it's going to give us an overview of how we're going to do this particular skill. Now, right now, you're at the very beginning of week 2, and this is still all very new. And you're still trying to kind of wrap your head around all of it and figure out how all these pieces go together. By the time we get to next week, when I show you these introduction pages, right, these overview pages, you're going to be rolling your eyes because, yeah, I got another washing skill. Got it. Right. Privacy blanket. Yep. Know all about those. And it's going to really start to click, to settle in. But right now, you're still very new and you're right where you need to be. If you're a little uncertain, that's okay. I'm not done with you yet. So cut yourself a little break and just follow along with me. And as long as you do that, by the time we get into next week, it'll all be second nature to you. Okay? So if you're looking at this overview page, down the side there, you can see all of the principles that are going to be involved in this skill. And they're all spelled out for you here. All of those banners that we're going to follow are spelled out for you here. And there's a lot of them. This skill has a lot of principles. So that means that there's a lot of steps that we're going to have to get checked off. But do you guys remember me saying that half or more of every skill is going to be principles? You guys remember that? So if we learn the principles and we know the principles, well, those are easy check marks for us. For instance, how do we know what to do with each patient? Care plan. So what's the first, if somebody asks you to do a skill, what's the first thing you need to know?
Care plan.
Care plan. Yeah. What do you want me to do? How do I need to adapt this skill to this patient? Make sense? If we're going to do any skill, that means that we have to do the opening. You got to enter the room to do the skill. So we're going to do the opening. If we're going to do any skill, we got to figure out if we need gloves. If we're going to do any skill that requires supplies, well, now we need a place to put them. If we're going to do any skill that requires we take the sheet away, then we probably need a privacy blanket. If we're going to do any skill that requires us using linens or soft items with the patient, we have to follow the linen rules. If we're going to do any skill at all, once we're done with the skill, we've got to end it with the closing. We already know those steps. So if you look at all of this up here, right, it looks like a lot of banners, right? There's a lot of banners there. There are 9 of them. We're only going to learn 11. And this is already testing us on 9. This has got to be a hard skill, right? But when you look at that, you start to, okay, wait a minute. I know that one. 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 And I know that one. Oh, all I've got to do is learn 3 things and I know the whole skill now. Good. At the bottom is your test specific information. Somebody with your level of experience, that's none, should be able to do this skill in 11 minutes or less. 11 minutes or less. This is going to be done on another live person, so you might be the patient for this. Guys, this is a mini mani. We're going to soak a hand, wash a hand, rinse a hand, dry a hand, clean under the nails, file any rough edges, and put some lotion on. That's the entire skill. The whole thing. And you got 11 minutes to get that done. That is way more time than you need. Way more time. So take your time, breathe through it, don't rush, because when you rush, you forget steps. Good? So let's figure out how to do this skill. So if you go to page 117, the very first thing we need to know for every skill that we do is the care plan. So on this page, where would I find the care plan? Where do I find the care plan? Yeah, page 117. On the top where it says care plan. There it is. Right there for you. This is the testing care plan. So if you get hand and nail care on the test, this is exactly what your care plan is going to say for the test. This is it. Provide hand and nail care to 1 hand. What if the patient has 2? Why? Yeah, because we're going to follow that care plan. For the test, they let you pick. Yeah, for the test, they let you pick. Now, in a clinical setting, if it says 1 hand, because most people have 2, right? If they only want you to do 1, that means there's a reason that we're not doing the other one. So they would tell us which hand they want us to do. But for the test, they leave it open. It's just going to say 1 hand. The evaluators, they don't care. As long as they see you do it on one side, they don't care. They know you know how to do it. They don't need to see it on the other side. So 1 hand is fine. We get to pick. Now, the reason for that. So, guys, remember I said this test is very scientific? Nothing to chance. Let's say that you are the patient for you to do hand and nail care on, but she's got a brand new kitten and she's right-handed. Are you right-handed?
Yeah.
She's right-handed, so she plays with the little kitten with her right hand, you know, feathers and little mice and stuff like that. So her right hand probably has all kinds of scratches on it. So when she comes in for the test and I check her in as the evaluator, I see those scratches on her hand. Now I know that I'm going to put her with you. Long story, but I know that I'm going to put you two together. I know she's got some scratches on the right hand. So I'm going to tell you, here's your care plan, but I want you to do hand and nail care on her left hand, please. It leaves it open for the evaluators because I don't want you around her scratches, right? Those are body openings. Make sense? It gives the evaluator some latitude there. Questions on that? All right. So the care plan says provide hand and nail care to one hand. The resident is sitting in a chair at the bedside table and can move as directed. So it's me sitting here at this table, and I can do whatever you ask me to do. Okay. So for the test, hand and nail care, we're going to soak the hand, wash the hand, rinse the hand, dry the hand, clean under the nails, file the rough edges, and lotion the hand. That's the skill. It's not going to take me 11 minutes to do. It's pretty quick. But let's talk about why we're doing it, because I find it much more helpful for you if you know why you're doing some of these skills. Well, this particular skill is usually going to be done in long-term care, places where people live. We don't do hand and nail care at the hospital. There's no need for that. People there are short timers. They can go home, take care of their own hands, their own nails. I'm not worried about them. But in long-term care, we're taking care of more of their daily tasks. So hand and nail care actually becomes very important because if your patient needs help, chances are they aren't washing their hands at the sink very often or very well. So this helps provide a level of cleanliness, kind of focused cleaning. Make sense? The other reason, though, is probably a little more important. CNAs do not use nail clippers. Nail clippers are advanced pieces of medical machinery that you're not allowed to touch. CNAs do not clip nails. Most nurses don't even clip nails. If you can find a pair of nail clippers at a nursing home, you have accomplished something fierce, because we usually don't even keep them on the premises. So if we don't have nail clippers and we're not using nail clippers on the patients, you can imagine just how long their nails are going to grow. And that becomes an injury risk to the patients themselves, but also to others, staff members, other patients. We can't have that. So we've got to, without nail clippers, figure out a way to keep the nails a manageable length. And it turns out if you file nails on a regular basis, they never grow past that point. So hand and nail care is all about cleaning the hand, but also filing the edges to keep them at a manageable length. Now, one of the things that we're going to find out is that as we age, our body goes through some changes. And one of those changes is nails just don't grow as quickly as they did when we were younger. So by doing hand and nail care once a week, filing the nails, your patient's nails will stay at that length pretty much forever. That is why we do this skill, so that we don't have to clip them. Good? Questions? Okay. You are responsible for learning supplies. We've talked about this before, but this is where it's starting to get a little real, because this skill has some supplies. You're going to need a basin. You're going to need soap, lotion, 2 washcloths, a towel, an orange stick, and an emery board. You may also need gloves if they have any openings on their skin, rashes, wounds, scratches, anything like that. If they have no rashes, wounds, scratches, you don't need gloves. You're going to wash your hands before and wash your hands after. But there's a lot of supplies there, aren't there?
Mm-hmm.
You've got to learn them. Nobody's going to tell you, okay, I need you to go do hand and nail care, and I want you to take 2 washcloths, a towel, a basin, soap, lotion, emery board, and orange stick. I don't have time to do all that. I'm just going to tell you, go do hand and nail care. Good. Make flashcards. You've got to learn your supplies, because if you don't have the right supplies, you're going to miss the steps that you need to be successful. If you don't grab the lotion, then you don't have lotion to put on, and you might forget to put the lotion on. Good?
Mm-hmm.
Make flashcards. If you want to order mine, they're on sale for you. See Jake. $14.99 until graduation. All right, so here is our care plan. Here are the principles that are going to allow us to do the care plan. And here are the skill-specific steps. And we're going to go through all of these one by one so that we can learn how to do this skill correctly. Now, unfortunately, there's 2 principles that we do not know yet. So we've got to go over those. We've got to learn these. Now, the thing about these is that we're going to use them a lot. A lot. A lot of what CNAs do are going to revolve around keeping the body clean. We do a lot of cleaning. So learn them once and use them over and over and over and over and over again. So we're going to learn washing rules. This is on page 112. All right. So our notes are going to be located on page 113. You don't need to take notes, but we do need to kind of discuss how bathing happens, because we are on autopilot and we don't really stop and think about it too much anymore. So let's take a step back and look at big picture here. Think about how you bathe. You get wet, right? You turn on the shower, get it a nice comfortable temperature for you, get in and you get wet. You don't put soap on a dry skin, do you? You get wet first, and then you soap up. What do you do after you soap up?
Rinse.
You rinse off. And then once you're done rinsing, you get out and you
Dry off.
dry, right? Those steps are pretty self-explanatory. We know what to do. You wouldn't ever jump out of the shower with soap on your skin and shampoo in your hair. It just wouldn't make any sense to you. It would feel very odd. Now, that's because you're doing these steps on you and you've developed a routine and you just go through the motions. You don't even think about it anymore. Your brain is occupied in other things. You're singing in the shower, whatever. The problem is that we're not doing these skills on us. We're doing them on another body. And it's really easy to forget these steps. Really easy. Like about half of the people that take the test forget one of these steps. So as we're doing this, we're going to have, just like no knobby knees, you know, my little sayings, right? Whatever I wash, I rinse. Whatever I rinse, I dry. That keeps us on track because it's really, really easy to forget. You wouldn't think so, but when you start practicing this, you will forget. Okay? So think about how you bathe. So if we know that we have to rinse something. Now, in the shower, it's easy. You got water coming out of the ceiling, right? You got water right there. So you get wet, you soap up, you jump back in, and you rinse off. It's super easy. Everything is right there. But when we're bathing somebody not in a shower, if we're doing hand and nail care, we brought the water to them. The water's sitting there. So sometimes it's kind of easy to overlook, oh, I got to rinse, right? Because that water isn't coming from the ceiling. You can't really see the suds either because we're not using sudsy soap. But what a lot of people do when they're doing this skill is they put soap in the basin. Okay, they put soap in the basin. So let me give you an exercise just to so you can see how this would go. Think of your shower head. Okay, think of your shower head. So the shower head is raining down, it's bringing water. Is that water clean or does it have soap in it? Clean. So if you hooked up an apparatus so that water sprayed soap on you, would you be able to rinse with it?
No.
No, because every time you got in the water, you would be getting more soap. Make sense? Okay. If you put soap in the water, that's exactly what you've done. You have no way to rinse now. So we don't put soap in the water. Basins are no soap zones.
So how do we soap them up?
Okay, hold up. Hold up. All right, so basins are no soap zones, and that's because whatever you wash, you have to rinse. Whatever you rinse, you're going to dry. It's that rinsing part that we have to be concerned with. We need clean water to rinse with. So if you put soap in that basin, you've lost your clean water to rinse with. So,
two basins?
okay, so let's talk about that. Okay, let's talk about two basins. Sure, you could use two basins, but everything that you use for that patient has to pay for. So I want you to imagine going out to eat. Anybody ever go to a restaurant to go out to eat? I want you to imagine going out to eat. Now, normally when you go out to eat, you judge where you're going based on your budget, what you can afford. You don't go to Prime 88 every day of the week because if you guys have got that money, you want to adopt me? Okay. You save those big dinners for special occasions, if at all. So it might be a McDonald's budget week, right? You go out to eat based on what you can afford. Make sense? Now, I want you to imagine that a brand new restaurant opens and you want to try it out. So you walk in and you sit down and you expect a menu so that you can decide what you want to eat off of their menu. They go, oh no, that's not the way we do things here. We will bring you what we think you need. So you don't get to pick. They're going to bring you food. Now, you're probably starting to wonder, how much is this going to cost? And they go, oh, well, we'll give you a bill at the end. Don't worry about it. We'll give you a bill at the end. So now they bring out a whole bunch of stuff that you didn't ask for and you really don't even want, and you certainly don't like because you didn't get to pick it. And then they give you a bill at the end that's about as expensive as a brand new car. And they say, oh, well, if you can't, you've already received the service. You've already seen the food. If you don't pay this, we're going to take you to court. And we're going to garnish your paycheck. And we could possibly even take some of your possessions. So will that be cash or charge? That's healthcare. You do not get to decide what you get. And you probably don't even want half of what you got. You are not aware of the pricing of what's being provided. And at the end, you get a bill. And if you cannot pay it, they will take you to court. One day a month in this county is healthcare collections court. So, two basins. That is adding a charge onto your patient's bill without their knowledge or consent. And those basins are going to cost about $38 a piece.
Wow.
I'm in my own business.
Yeah. The hospitals don't shop at the Dollar Tree, guys. Do you think that you would be okay getting a bill full of items that you didn't want, but you have to pay for? We've got to be very careful about the supplies that we choose to use for the patients when we don't need them. Does that make sense? Good? Yeah, I know, me too. I'm in the wrong business. All right. So we know we can't put soap in the basin, right? I'm going to tell you how to do this in just a second. Stay tuned. Stay tuned. When we're going to go get that water, and I need to lead you there first. So when we're going to go get the water in the basin, we have to think about when we're doing this. Okay, so I've walked in. Hi, Miss Jones. My name is Patty. I'm your CNA today. I need to do hand and nail care. Is that okay? I'm going to close your curtain, go wash my hands. And now I need to get my supplies. So I'm going to get a barrier, put it on the table. I'm going to get my supplies, put them on the barrier. Now I need to go get water in my basin. So my hands are clean and all I've touched are clean things. But that faucet is not clean. So when I take this basin to the sink, I have to be aware that faucet is not clean. I can't touch it with my clean hands. So I'm going to get a paper towel between my hand and the faucet to turn it on, just like I turned it off earlier when I washed my hands. So I'll turn the faucet on with a paper towel. I'm going to use the inside of my wrist to feel the temperature. And that temperature should be warm, not hot, not cold, just warm. But just because I think the temperature is okay doesn't mean my patient is going to agree. And we all have different temperature preferences. Me, when I shower, I like hot. I want my skin to be flayed off by this shower heat, right? I want hot. The hotter, the better. Now, my husband, just the opposite. He likes cool. He works outside in the heat all day. He doesn't want a hot shower. He wants cool, right? So if he jumped into my shower when I have the shower running, he's going to be screaming because this is not what he thinks is comfortable. We all have different temperature preferences. Don't assume that the way you like your water is how your patient likes their water. So we are going to ask them, how does the water feel? We're going to get them to test the water. But there's another reason for this as well, okay, beyond temperature preference. And it has to do with aging. As we age, each layer in our skin is going to shrink. So when we're young, we've got our skin layer, our fat layer, and our muscle layer, and they're all nice and plump, well vascularized. But as we age, those layers actually start to shrink. And when we get into our older years, when we're looking at the elderly, that layer of fat in their extremities all but goes away. And you've actually seen this without even realizing it. Have you ever seen the hands of an old person? They look like this. Your hands don't look like this. So that means that as we age, there is a physical sign of aging that we can actually see. We see this happen. If you look at those hands, there is not a layer of fat there. It looks like skin over blood vessel. Good. I still have fat layers. They are shrinking though. I'm not going to be able to get away with this too long. Yeah. So temperature perception for me is going to be different than temperature perception for that person. You see that? But let's talk about why. What does that fat layer do? So that, what we call subcutaneous fat, especially in the extremities, does two very, very important things. And when we lose it, there's a huge repercussion in the body. So let's talk about what it does. What is your normal body temperature?
98.6.
Okay, so 98.6 is our normal body temperature. It's actually kind of a range, 97.6 to 99.6, but we usually just use that 98.6 as our benchmark, right? Okay. So if you reach over and touch her skin, she is 98.6 degrees right now, sitting right here. But if you walked outside and the temperature was 98.6, how would you describe that? Hot. That's right. So we're all hot. Haha. Okay. So 98.6 degrees. We all think that's hot as far as the temperature goes. But room temperature is not 98.6 degrees. We aren't comfortable at 98 we would not thrive in that heat. It would be too hot for us. Room temperature is actually closer to about, let's just make it an easy number, 75. I like easy numbers to work with, okay? Some of you like it a little cooler, that's fine, but let's just stick with 75. Good? Are you with me? Okay. So 75 is room temperature, 98.6 is body temperature. Let's talk about a pie. If you take a pie out of the oven, it cooked at 325 degrees. When you take it out of the oven, the pie is 325 degrees. That's hot. Too hot to eat. We can't eat it yet. It's got to cool. So we put it on top of the stove and we let it cool for a couple of hours. Does that pie stay at 325 degrees? No. When we put it on top of the stove, it's going to cool down. Do you know what it's going to get to?
Room temperature.
Room temperature. That's right. It'll cool right down to whatever the temperature is in the room and it'll stay there. It doesn't ever go colder than that. It stays there. So pie always goes with ice cream. So let's get a thing of ice cream out of the freezer. And when we get the thing of ice cream out of the freezer, it's about, 0 degrees or 3 degrees, whatever your freezer is set to. It's cold. But you set that ice cream on the counter and leave it there. What happens to the ice cream? Why? It is now warmed up to room temperature. So here's a principle for you guys. Room temperature always wins. If something starts out hot, room temperature will cool it down to room temperature. If something starts cold, room temperature will warm it up to room temperature. We call it ambient temperature, and it always wins. Always. There has to be an active source. So we either have to use an oven or a freezer to alter things out of room temperature. Because if we just left it out, it would be room temperature. Does that make sense? We are not room temperature. We are 98.6 degrees, but we live in room temperature. So that means that there is an active process inside us that has to get us to 98.6 degrees, that has to overcome room temperature. Have you ever heard the term burning calories? That is why you burn calories, to create heat. That heat gets us to 98.6 degrees. It is an active process. But that takes a lot of work. Oh my gosh, that takes a lot of energy to keep you at 98.6 degrees when your body's constantly fighting room temperature. Are you following me? So we have this layer of fat, and it acts as insulation, like a wetsuit. And it holds in that body temperature that we're creating. So our body doesn't have to work as hard to fight against this outside room temperature stuff. So we create some heat, and that body fat keeps that heat inside, and now our body doesn't have to work as hard. The heat doesn't radiate away as quickly. That is why you can sit next to her and you're not blasted by heat. But if you put enough people in a room for long enough, that room will heat up through body temperature. So we are radiating some. But that layer of fat helps kind of keep most of our body temperature inside. It also blocks out outside temperature. So if it's super hot outside, your body is able to kind of regulate. It doesn't allow that outside temperature to affect it too much. Your temperature might go up a little bit, but not a lot. If it's super cold outside, that layer of fat helps block that out so it doesn't lower your body temperature too much. It keeps you in a nice, comfortable range. Now, this range is very narrow, very narrow. 98.6, that's where we live. If we get a fever, fever is anything over 100.5. That's not very much. 98.6, 100.5, it's only like 2 degrees. And we are qualified as having a fever. So anything outside of that 98.6, it doesn't take much to get us outside of our comfort zone. But if we go the other way, 2 degrees the other way, you're at 96. It's hypothermia. Anything under 95 outside is still hot. But anything in the human under 95 degrees is hypothermia. Under 93 degrees, you're dead. This is a very narrow range. Very narrow. And this layer of fat helps us keep in that narrow range. So it's important. Until you lose it. So let's talk about what happens to the elderly people when they lose this layer of fat. Well, the body heat that their body is trying to generate is going to radiate away. Their basal temperature will be a little bit lower. They're not going to be able to get and stay at 98.6 degrees. But even more than that, without this layer of fat help holding things in and blocking temperatures out, right? Their perception of temperature is going to be different. They're always going to be cold. Does that make sense? Have you ever walked into grandma's house and you're like, Grandma, turn on the AC. It's like 85 degrees in here. It's hot. It's hot. And Grandma's like, oh no, I'm fine. It's good. I'm fine. It's so that her body doesn't have to work as hard to overcome room temperature. She's right. She is fine. It's also why we hear older people say, yeah, I can't live up north anymore. I can't handle the cold. It's because they've lost their wetsuit. Does that make sense? But it also means that their perception of temperature is going to be way different than ours. So I feel that temperature with the inside of my wrist, and it feels warm, not hot, not cold, just warm. But when I ask my patient to feel it, they may come up with something totally different. To them, it might feel cold, or it could feel very hot. When we ask our patients to check the temperature, if they say, oh no, this doesn't work for me, what should we do? Should we argue with them?
Change the water.
Yeah, adjust it. Absolutely.
How do we get soap on their hands and rinse
Hold on.
them?
I know, I'm not there yet. Hold on.
Okay.
I need you to understand water temperature before we get into the mechanics of actually washing. Do you guys get this? So that layer of fat does a few things. It's going to keep outside temperatures out. It keeps inside temperatures in, but it also affects how your patients perceive temperature as well. So don't ignore this, guys. Don't argue with the patient. And I've seen CNA, I got very angry at a CNA one day for arguing with a patient over whether water was too hot. It's not your place. It's not your place. Your patient says it's too hot. Believe them. They're not trying to make your life difficult. You're making theirs difficult. Okay, good, good. So we're going to check the water, and then we're going to ask our patient to check the water. This is a critical checkpoint. If you don't ask your patient to check the water, you could possibly fail the test. Because help isn't help if it doesn't help. If you are forcing the patient to bathe with water that's uncomfortable, that does not help. Good? Good. All right, so this is our order. Whatever we wash, we rinse. Whatever we rinse, we dry. And we have a basin of water that we're going to use to rinse with. So we soak the hand to get it wet, and then we're going to use that basin to rinse the hand. But the basin does not, the basin is not there for washing. It's there for wetting and rinsing. So we put the hand in the basin to get it wet, and then we take it out to wash it. We're going to set it on a towel. We don't want it on a hard surface. We want a soft surface. So set it on the towel. We're going to take a washcloth and wring it out really well and put soap directly on the washcloth. Now, for the test, and in most clinical settings, we are going to use something other than hand soap. So we don't have, like, you know, the hand soap that we have in the bathroom there. We have spray soap. This is non-sudsing. A lot of them will say no rinse. That doesn't mean that we don't rinse. It just means it's not going to suds up really well, okay, like our hand soap does. So we're going to use something like this for the state exam. So we wet our washcloth, wring it out. No drippy wet washcloths. Wring it out, put soap on the washcloth, and then wash all surfaces. Now we're going to take that clean hand and put it back in the basin to rinse. Does that help?
Yes, thank you.
Okay. Then we're going to take it out of the basin to dry. Now, this is why rinsing is so important. If you look at the skin under magnification, when you don't rinse soap off, this is what it looks like. It dries out the skin, can actually cause cracks to form, but it becomes very itchy. So rinsing is more important than you think it is. Okay. Good. We're going to change the water if it gets cold or soapy. So if you've got 11 minutes to do this skill, we're going to get our water. We ask our patient to check it. They say it's fine. If we take forever to do whatever, and by the time we get around to using the water, it's cold, change it. Address it. Don't ignore it. If for some reason you get the water soapy, change it. We don't want this. So if you accidentally add water or add soap to the water, go change it. Don't ignore it. It's about the patient, not you. Good? Good. All right, make sure your surface remains dry. This is why we use a barrier on the table, absorbent side up. If we're working with the patient in bed, put something on the bed so that we're not getting the sheets wet. If we're working on the floor, put something on the floor so we don't get the floor wet. Protect your surface from getting wet. When we put lotion on, we warm it up first and then wipe off the excess. Don't squirt cold lotion onto somebody. That's just mean. It's mean. Don't do that. Some people will put the lotion bottle in the water to warm it. That water is not warm enough to warm the lotion. But you're only, even if it does, it only warms the outside of the lotion. When you squeeze lotion, you're squeezing from the middle. So putting a bottle of lotion in the basin does not warm it. Just put it in your hands and warm it. It's the best way to warm lotion. Warm it. And then we wipe off the excess. Good?
Very quickly, the bottle itself will actually, you will transfer heat to the bottle when you do like this.
No, you want to get lotion out.
Okay.
Squirt lotion on your hand. Yeah, don't squirt cold lotion on the patient. Put it in your hand and then warm it up by rubbing your hands together. I should have been more specific on that. Sorry.
But initially, you said let the patient test the temperature of the water. What if they're dirty, or you know what I mean? Are you changing that water after they tested it?
Okay, so good question, and I'm going to answer that in two ways. If I have a patient that I'm working with that has been in this facility for 6 years, and I have done hand and nail care every week for 6 years, and I'm diligent about, they get bathed twice a week, and basically the whole reason I'm doing this is to keep their nails short. Okay. There's nothing, they're not introducing a lot of stuff into the water, right? So I'm pretty safe. But let's change this up. Let's say this is a brand new patient, just got here yesterday, and he's been homeless for the last 6 years. So he's got quite a bit of stuff on his hands. So when I put the hand into the basin, it's going to get gunked up pretty quick. So I'm going to bring his hand out, go change that water, right? I don't want to leave his hand in that water. Get some new water. Have him check it. Yeah, it's fine. Put the hand in. If the water still is gunky, I'm going to go change it out again. And I'm going to do that until that water is clean. Then I'll wash his hand. Yeah, if the water gets cold, soapy, or gunky, change it out. Okay. Chances are you're not going to run into that. Most of the time when we're doing hand and nail care, it's on established patients. It's just a way of cleaning the hand and basically getting to those nails. Okay. Now let's learn about basin cleaning. Now, this is really going to mess some of you up, and I know that. So I want everybody to take a deep breath. Cleaning a basin is easy. We're going to rinse it, we're going to dry it, and we're going to put it away. Everybody good with that? Cleaning a basin is easy. You're going to rinse it, you're going to dry it, and you're going to put it away. It's going to look a little more complex when I get into the steps, but I want you to remember, cleaning a basin is easy. I'm going to rinse it, I'm going to dry it, and I'm going to put it away. So if you get overwhelmed, what do you need to remember about basin cleaning? Okay. Now, some of you are going to go down a yellow brick road. And you're going to think to yourself, well, I need to disinfect it. I need to clean it somehow. For the test, what are we going to do with our basins? Okay. You are not going to clean or disinfect the basin. That does not mean in a clinical setting that your policy and procedure might not have you cleaning the basin, or your care plan may have you cleaning a basin. Every situation is different. If I've got a patient on chemotherapy, I'm intentionally killing their immune system. I want their basins disinfected. Your care plan will tell you to disinfect that basin. Remember, we always go by our care plan. You good with that? Good. But for the test, what are we doing? Rinse, dry, put it away. So I'm going to show you a method that covers both. What we're going to do for the test is rinse it, dry it, and put it away. But we're going to do that in such a way that if we have to disinfect for any reason in the future, we just have to add that step in. There's a placeholder for it. Okay? So you don't have to reinvent the wheel out there. You're using the same method. We're just going to disinfect when it comes to that point. Good? All right. So basin cleaning Our overview is on page 90. Do you see how many skills we're going to have to clean something? But for the test, all we're going to do is rinse it, dry it, and put it away. Some of you get all caught up in the cleaning part. Don't get caught up in the cleaning. Don't go there. All right. These are our notes, page 91. So if we're going to clean a basin, that means there's something in it. We used it for something. Now, a basin could be a bath basin like this, or you don't see it on there. Could be a bath basin that we use for hand and nail care. It could be an emesis basin that the patient spit in for mouth care. It could be a triangular graduate container with urine in it. It could be a bedpan. If it's plastic and it's hard and we've got to clean it, it's a basin. But that basin is going to be holding something. Where do we put that something? Well, where it would normally go. Sink or toilet. If you're working with saliva, how many of you guys brush your teeth over the toilet? A little weird, right? So if it normally goes in the sink, like you brush your teeth over the sink, if it normally goes in the sink, put it in the sink. Most of you guys don't pee in the sink, and if you do, I don't want to hear about it. So if it's urine, where would it normally go? Toilet, right? So put it where it normally goes. Now, some of you guys are going to get really creative with this, and you're going to think, well, if it's below the waist, it's got to go in the toilet. It doesn't matter. If it's bathing water, put it in the sink, right? It's bathing. It's fine. We don't put anything dirty back in the basin. You're really just working with water, guys. Water for bathing. That's it. Water. So, but a lot of you are going to try to really complicate this, and that's why I'm really trying to simplify. We just rinse, dry, and store. That's it. Put the stuff where it normally goes, rinse it, dry it, store it. That's all you got to worry about here. Okay, good. All right, so we've dumped our basin wherever it normally goes. Just dumped it in the toilet or the sink or whatever, but now we've got to rinse it. So when we rinse the basin, we can touch that faucet perfectly okay, because the faucet is dirty, and by now, so are we. We're done. This is the end of the skill. We're done. So our hands are soiled. So dirty hands could touch a faucet, that's fine, no problem. If you want a paper towel, use one. I don't care, nobody does. But you don't need one here. You only need a paper towel to touch the sink if your hands are clean. So we're going to turn the faucet on, we're going to rinse the basin. And then we're going to dump that rinse water wherever we dumped the stuff that was in the basin. So if this is urine and you dump the urine in the toilet, when you rinse the cup, dump that in the toilet as well. Good? Okay. All right. Once we've rinsed it, this is where it gets a little complex. I told you for the test, we're just going to rinse, dry, and store. That's all we're going to do. But in a clinical setting, if we have to disinfect, if it's on our care plan or our policy and procedure, if we have to disinfect, that changes things, because we can't hold something while we're disinfecting it. Your hands are not clean. So if we dumped it, rinsed it, and dumped it, and we have to disinfect it, we can't hold it while we're disinfecting it. So we're going to set it down in the sink. Good?
Regardless if you dump the urine into the toilet and all that stuff.
Right. So we dump the basin wherever it normally goes. We rinse the basin and dump that wherever we dump the stuff. Okay. So if we dump saliva in the sink, we rinse it, we dump it in the sink, and then we set it down. Not hands off, not touching. Once we're hands off, if we have to, now we can spray it. But now that basin is clean. It's been disinfected. can we pick it up with our hands or our gloves? Because they are not clean. So what could we use between our dirty hands, gloves, and the clean basin? Paper towel. So we're going to use a paper towel to pick it up. We're going to use a paper towel to dry the inside. We'll use a different paper towel to dry the outside because we didn't spray the outside. And then we're going to use another paper towel to open the drawer. Good? Do you guys understand why? Okay. So remember, essentially all we're doing here is rinsing, drying, and storing. That's all we're doing. We're going to rinse it, dry it, and store it. But in between the rinsing and the drying, we're going to set it down in the sink. We're going to use a paper towel to pick it up. Because if we did have to disinfect it, it is now clean. So the whole process is exactly the same, whether we're disinfecting or not. We're just not spraying it. So dump it, rinse it, dump it, set it down, spray it if necessary. Paper towel to pick it up, paper towel to dry the inside, throw that away. Paper towel to dry the outside, throw that away. And then grab one more to open the drawer. Along the way, you can pick up your soap and lotion with that drawer paper towel and put it in your basin to put it away. Questions? Okay. Now, some of you are like, well, hold up. That soap and lotion isn't clean. You're putting it in the clean basin. Don't think about that. Just move on. Move on. And that's because we're not trying for sterile. We're trying for as clean as we can. Okay. It's like you at home. When you brush your teeth, you probably get the big globs of toothpaste out of the sink and you move on. You don't disinfect the sink every single time you use it. You probably do it once a week or when company's coming, whatever. Only when it's necessary. And that's what we're doing here. Okay, Tasha says, so the bottom of the basin is not considered germy once it hits the sink. Yeah, it is. Not germy, it's just considered unclean, which is why we use a different paper towel. There's a whole infection control protocol that goes along with that you as CNAs are not responsible for. That would be a nursing thing, okay? As a CNA, all we have to know is that the inside of the basin is considered clean once disinfected, not the outside. Sterile is a whole different beast, guys. Whole different beast.
Just a question. You rinse it after you're done rinsing it clean. You still want to set it down, even you're not disinfecting.
Right. I want you to get used to the process so that out there, all you have to do is add in spraying. You've been doing everything else all along. Every time you clean a basin. Okay.
That's what the care plan calls for.
We're only disinfecting if the care plan calls for it. Correct. Correct. Now, disinfecting might actually be squirting soap in it and washing it. It could be disinfecting with a disinfectant wipe. It could be disinfecting it with a spray. There's a lot of different ways of cleaning. I want you to get used to the process. Okay? You're going to see this over and over and over and over. Good? Questions? All right, you're going to see a lot of basin cleaning in this class. You'll get it. But I want to reiterate that this really is this simple. For the test, we rinse it, we dry it, and we store it. Nothing else is graded. So if you don't use paper towels, it's fine, to pick it up. They're not grading you on that. I want you to get used to it. But for the test, rinsing, drying, and storing is what they're grading us on. But I want to make you functional beyond the test. I might be the body in the bed. Of course, I don't think I can afford healthcare anymore, but that is what it is. All right. So these are our checkpoints for this skill. This is when you're testing for hand and nail care, this is everything that they need you to get checked off. Everything up there. It's a lot of steps. That's a lot of checkpoints. Good. You with me? I want you to notice how many of them have no color at all. They're just white. Not very many. Almost about 3/4 of this skill are going to be checked off by those principles. We haven't even talked about hand and nail care yet. We haven't gone over how to do hand and nail care. We've talked about the opening. We've talked about barriers. We've talked about gloves. We've talked about linen rules. We've talked about washing rules. We've talked about how to clean the basin. We talked about the closing, and we got all of those things checked off. We have not even touched hand and nail care yet. And we got about 75% of that checklist done. So let's learn a little bit about how to do hand and nail care. Now that we know all of those principles, let's get into the skill specific stuff. Okay. All right. So first thing we're going to do is read that care plan. We're going to do our opening, decide if we need gloves. We're going to get a barrier. We're going to get our clean supplies, and we're going to get our water, asking our patient to check it. And then now that we have the water, we're going to ask our patient to soak their hand in the basin. For the test, it's not a specific time. You don't have to stand there for 2 minutes and stare at somebody. How awkward would that be? You're just going to have them put their hand in the basin. But in a clinical setting, the longer you let the hand soak, the easier it is to get any debris that might be under the nails. So let them soak for a few minutes. It's okay. All right. After soaking, we're going to take the hand out, put it on a towel to wash. We'll get our washcloth, wring it out really well, soap the washcloth, and then wash all surfaces. After the hand has been washed, we're going to put it back in the basin to rinse. Support the hand as you move it. Once you have it rinsed, we're going to take it out, put it back on that towel to dry it. After we dry it, we're going to clean under the edge of the nail with an orange stick. An orange stick is also called a manicure stick. It has 2 ends to it. One is slanted, one is pointed. We use the slanted side. We want to be bevel up to act as a scoop. Okay. I'll show you what that looks like. This is an orange stick. Hey, Jake, can you zoom? Zoomy zoom.
A little tricky here, sorry.
You're fine. Okay, it's good. Okay, so this is a slanted end. You can see that it's beveled. Can you guys see that? This is a pointed end. Don't use the pointed end. We're going to use this end bevel up. So we're going to put this right under the edge of the nail. Can you guys see that? And you're going to circle it and then wipe it off, because I don't want dirt from this nail to be put under this one. So we just put it under the edge of the nail, circle it across the nail, wipe it off, and then we'll do the same for this one. Wipe it off, wipe it off, and so on. Good? Okay, Jake, unzoom me. Pass that around so everybody can see it. All right, and then we're going to take an emery board once we have that done. Oh, hold on. So under the edge of the nail. Oh, nope, nope, nope. And wipe it off in between nails. Then we're going to take our emery board and we're going to file toward the center in one direction only, toward the center. Some of you guys, because you guys are young, you don't know this yet. As we age, like our body goes through all kinds of changes. One of the changes is our nails get more brittle. So if you take an emery board like this and you go across the nail really fast, like you guys do when you're, filing your nails.
In a hurry.
What that does is it actually, you have collagen, so your nails are very flexible. Your nails can tolerate that. But as we age and we lose that collagen, our nails become much more brittle. They're less elastic. So as we're pushing the nail in one direction and pulling the nail back, it can actually split right up the middle. And it's very, very painful for patients. It'll split all the way to the cuticle. And then eventually the nail will fall off. It's very painful for patients. And it's because of that brittleness in the nail. It can't tolerate that longitudinal stress. So we just take a nail file and we go in one direction toward the center. Just like that. And then this side goes toward the center. And then if you end up with a point at the top, you just go across the point to knock it down. But what you don't want to do is this. Good? Just split my nail. So that's a nail file. You guys can see how to work that for those of you that aren't used to nail files. All right. So to recap, we soaked the nail. We soaked the hand, took it out, put soap on the washcloth and washed the hand. We put it back in the basin to rinse the hand, took it out and put it on a towel to dry the hand. Then we cleaned under the nail with the orange stick, beveled end, wiping it off in between nails, and then filed the rough edges toward the center. Once we're all done with that, we're going to get a little lotion on our hands, warm it up really well, put it on the hand. And then once we put lotion on, you have to wipe off the excess because at some point the skin will stop absorbing the lotion. Whatever's left lays on the surface of the skin and now becomes a slipping hazard. That person picks up a cup of hot coffee with lotioned hands, what's going to happen? Yeah, it's going to slip out. They're going to burn themselves. Absolutely. So anytime we put lotion on, we warm it up first and then we wipe it off. Good? Okay. Once we've got that lotion on and we've wiped off the excess, now we can clean up our work environment. So we're going to put our towels and washcloths and dirty linen. We're going to clean our basin. By the way, real quick, time out. When you use a washcloth, it does not go on the floor. Don't drop it on the floor. When you use a towel, it does not go on the floor. Don't drop it on the floor. It's going to go on an unused portion of your barrier. So you're going to have like a clean area, and then you're going to have an area you're putting your dirty stuff. When you take that dirty stuff to the hamper, don't hold it against your uniform. You're going to take it out, take it to the hamper, put it right in the hamper. All of those same rules apply.
Can we use gloves to apply lotion on them and like bathe them?
So,
Because I would preferably not do it barehanded, but that's just me.
okay. So my and I'm not trying to put you on the spot. Okay. But my question would be, what is the reason that you would want gloves on?
I don't like the feel of lotion, preferably, if I only can. And I don't like touching other people's skin necessarily, I guess.
Okay.
Business.
No, I
So
know.
no. And that's you're perfectly okay. All right. I don't want to I don't want you to think that your thought process is wrong. A lot of people in healthcare have that same thought process. And this is where gloves get used routinely. The problem with wearing gloves routinely is you stop thinking about the things those gloves are touching, and you end up ultimately putting your patient and the environment at risk because you're not really thinking about it. You're wearing gloves, and I would imagine that in your mind, those gloves are there to protect you. Right? I mean, that's kind of, and that's where I was trying to go, is that's kind of your thought process, is that you don't want to touch another human because they might have germs and you don't want those germs. Am I right?
Yeah.
Okay. And there's nothing wrong with that. There's not, but you have to go into this with the understanding that those gloves are not protecting you, not the way you think they are. because those pathogens are still going to get through the gloves. The gloves are porous. And as your hands sweat, you actually end up with more pathogens on your hand as they multiply. So washing your hands before you touch that patient is going to help keep your patient safe. But washing your hands after you touch the patient is what's going to keep you safe. Does that make sense?
Yeah.
Okay. Wearing gloves for doing routine tasks like hand and nail care, when you don't have any risk, there's no body openings, there's no body fluids, that type of thing. There's no need for gloves. It's also an expense. That doesn't mean that you're not ever going to use gloves for hand and nail care. If your patient is homeless, let's talk about our homeless guy, right? We had that homeless guy who's been out on the streets for 6 years, and I had to change the water 6 times. I know that there's probably some sort of body fluids in there. He didn't have access to a shower, that type of thing. So, yeah, I would absolutely wear gloves in that situation because my rule is met. There's a possibility of contact with body fluids. If I've got a dementia patient that digs in everywhere, okay, I'm going to wear gloves because there's a potential for contact with body fluids. If I've got a 72-year-old woman who is in an assisted living facility and she's, you know, showering herself and things like that, and I'm just doing this to keep her nails manageable, I probably don't need gloves for that.
Yeah, I think I was just thinking really about geriatrics and like all their cuts and bruises and skin tears.
Sure. Well, but that would meet our needs, right?
Yeah.
If they've got a skin tear, now there's a body opening.
Yeah.
And we have to understand that those gloves aren't just there to protect us then. They're there to protect them
Okay.
because that's a doorway in. Does that make sense? Okay. All right. So one of the things that I'm not trying to put you on the spot in
No,
any
you're
way
fine.
here, but you brought this up, so I want to address this, right? A lot of people have the mindset when they go into healthcare that they wear gloves for everything, and they have that kind of creepy, I don't want to touch another human type of reaction to this. But my question would be, would you shake hands with somebody? It's the same contact, right? And when we shake hands with somebody, we don't go wash our hands first and then go wash our hands after. Yeah, I mean, you guys are all going to interview. When you interview, you're going to have to shake somebody's hand. And you didn't wash your hands first, and you're not going to run to a bathroom and wash your hands after, right? So in reality, you come across other humans and you touch other humans on a much more regular basis than you think. Just because they're in a healthcare setting doesn't mean that they're any riskier. In fact, it's probably less risk because you're washing your hands so often. Does that make sense? Okay. But we have to look at each one of these as an independent thing. If I'm going to decide to wear gloves, it's going to be based on you and you alone, not the skill. But when it comes to lotion, I'm going to give you kind of something to think about, especially with geriatrics, right? The skin is very, very thin, easily bruised, easily prone to tearing, tissue paper thin. Gloves are going to provide friction. If you put gloves on, even with lotion, you are much more likely to tear the skin because the gloves themselves will actually provide friction against the skin. They're less forgiving. Does that make sense?
Yeah.
So if I were the nurse personally, as an RN, if I ask you to do hand and nail care on a patient that has super, super fragile skin, that I'm afraid that you might tear that skin with gloves, I'm probably going to tell you, I want you to do hand and nail care, but when you're putting the lotion on, be extremely gentle and please don't use gloves. But let me know if the skin tears. Because using gloves is probably going to increase the risk to the patient. Okay. Does that make sense? And to illustrate it, put on a glove real quick. Yeah, put on a glove, guys. Put on a glove, just one. Just put on a glove. Okay, you're going to work in pairs, so find a partner. I want you to, with a bare hand, with your bare hand, touch somebody's hand. And then I want you to touch that same hand with the glove. And feel the difference. Feel the difference in friction between the glove and the skin. It's rougher. Were you able to? Do you guys see that? Do you guys see the difference in texture and friction? Okay, you can take the glove off. So it's important that you understand as the CNA, I know you made that, didn't you? That's pretty good. As a CNA, there's information that you're not going to know. There are considerations that you're not going to think about. You probably never would have thought about the friction potential of gloves against elderly skin. That's why the nurses are so important in directing care, because it's our job to come up with all of these potentials, all of them. And our job is to keep both you and the patient safe, both of you. So we've got to come up with solutions that are going to meet that need. And if I can't, then it's my job to perform the care. It's my job. Does that help?
Patty, I believe we just randomly lost audio.
Oh, well, we're going to put on a video. We're good here. We're good here. Okay. My mic is still on.
Just turn off on your sender.
Nope. Let's put the movie on and see if that plays through.
Okay.
We're going to watch the skill for this, for hand and nail care. And then we'll take our break. And then we're going to get into making an occupied bed and then blood pressure. We're not going to be able to get to range of motion again. It's okay. I've got time built into the end of the program for the range of motions. But if you're following along in your syllabus, we're running a little bit behind today, and that's okay. It's pretty normal for me. My family calls it Patty Standard Time for a reason.
Ready?
I'm ready. Yeah. Please hold. All right, so stop the video for a second. Give me a second, guys. So hold on.
Audio.
We're going to,
So let's try this. Hold on. Let's see.
I'm telling,
Try that because maybe it's just a bandwidth issue.
we need to unplug the Rodecaster. unplug the road.
Hello.
Good morning, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm good. How are you?
Fantastic. I need to perform hand and nail care on one hand. Is that okay?
Yes.
Okay, I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. Now that I have clean hands, I can get my clean supplies. We're going to place a barrier on the table with the absorbent side facing up. This gives us a clean area for our clean supplies. And for this skill, I need a towel and 2 washcloths. We'll bring this over to the patient area. From our bedside cabinet, we'll get a basin, soap, and lotion, and an orange stick and emery board. We'll set these items on the overbed table. All right, Mr. Jones, I'm going to go get some water in the basin. I'm going to use a paper towel to turn the water on. Check the water temperature with the inside of my wrist. It should feel warm, not hot or cold, just warm. And we'll fill the basin about 1/4 of the way full. And then throw the paper towel away. Mr. Jones, would you like to check the water temperature? Is it comfortable?
Yes.
Can you submerge your left hand in the basin, please? Thank you. I'm going to put the washcloths in here. And we're going to rinse your hand using the first washcloth. And now I'm going to place your hand over here on the towel. I'm going to take the washcloth, wring it out really well, and apply soap. Now I'm going to wash all surfaces of the hand. The thumb, each finger, in between each finger, we'll clean the palm of the hand as well. And the webbing between the thumb and the index finger. I'll set that aside. Mr. Jones, we're going to put the hand back in the basin to rinse. And using the washcloth, we'll just squeeze water over the hand to rinse. I'm going to turn your hand over, and we'll rinse the palm as well. Okay. I'm going to lift your hand up and place it on this towel, and we'll dry your hand using the towel. We want to dry all surfaces. We'll go ahead and turn your hand over. Make sure that all surfaces are dry. And now we're going to clean your nails with our orange stick. We're going to use the beveled end of the orange stick. We're going to clean under each nail, circling it around and wiping it off on the towel in between each nail. So we'll clean under the nail and wipe. I'm going to repeat on all nails. And now that the nails are clean, we're going to use the emery board and file the rough edges. We always file in one direction toward the center. I'm going to repeat on all nails just to make sure that the nail edges are smooth and free of any rough edges that might accidentally harm the patient's skin. Once the nails have been filed, we'll get some lotion. And we're going to warm the lotion up in our hands before we apply it to the patient's skin. So I'll rub my hands together to warm that lotion, apply it to all surfaces. making sure to coat all of the skin surfaces. And then we'll take that towel and wipe off the excess lotion. That way it's not a slipping hazard if there's any lotion left on the surface of the skin. Now I'm going to take your linens and place them in dirty linen. I'll be right back.
Okay.
And I'm going to go clean your basin. I'll be right back. I'll bring the basin of water to the sink, dispose of the water into the sink, and rinse the basin. We'll dispose of the rinse water into the sink as well. I'll set the basin down, disinfect it per facility policy, and then use a paper towel to pick it up. I'll dry the inside with a clean paper towel. Throw that paper towel away. Dry the outside with a clean paper towel and throw that paper towel away, and then get one for the drawer. On the way, we'll pick up the soap and the lotion with the paper towel, place them in the basin, and use the paper towel to open the drawer. We'll slide this basin, soap, and lotion in the drawer and close it with the paper towel. Now we can dispose of our disposables. So the emery board and the orange stick will go in the garbage along with the barrier. So we're just going to put these directly in the garbage can. Mr. Jones, are you comfortable?
Yes.
Is there anything else I can get for you?
No, thank you.
Would you like a magazine before I go?
No, thank you.
Your environment is clean. I'm just going to move this table out of your way. Here's your call light, Mr. Jones. If you need anything at all, please press the button and let us know. We'll be happy to come help. I'm going to go wash my hands. After washing my hands, I'll review the care plan, make any corrections, and tell the evaluator my skill is done. Eight. All right. Any questions?
We can rewatch that video, that specific video.
Anytime. It's going to be in the wrap-up emails. The link is in there. It's also on our main website, foryourcna.com. It's also in the online course that you guys all have access to under hand and nail care. You can actually watch it on the live stream replay too. So lots of, and directly on our YouTube channel.
So for the part where you like clean the nails and you put it on the towel, do you use the same towel that you put the stuff from the nails to wash off the lotion, the extra lotion at the end?
Mm-hmm.
Just like fold it a different way?
Yeah, I just folded a different way. Yeah, it's fine.
She had two towels. She only got one towel for her supplies, one towel and she could washcloths. When she soaked up the hand, it was on one towel, and then when she rinsed it, after she rinsed it off, she put it on another towel. So do we need two towels or one?
No, and she is me.
Oh, really?
Yes. So yes, those are all me on the videos.
Okay. So observant.
So one towel.
Okay.
You have the towel on the table. You take the hand out of the basin and put it on the towel while you're washing it.
Okay.
You put the hand back in the basin, use a washcloth to rinse it, and then take it out. You're putting it on that same towel
Okay.
to dry it. Okay. It was just, I have a certain way that I fold them so that every time they're on the towel, it's a different area of the towel. So it may have
Okay.
looked different just in the way that it was arranged, but it's the same towel, just one towel. You can use two if you want. I don't care, but yeah, one is plenty.
Okay.
All right. I just saw this. I wanted to read it to you guys. This is on Facebook in Spring Hill Neighbors, Hernando County group. Okay. It says, looking for home health care, need care for a life-loving 94-year-old man. A CNA would be perfect, or experience and live in. Private room and bath, 24 hours a day. So anybody that's looking for a full-time live-in position, Job requires assistance with personal care, bathing, grooming, hygiene. You guys can all do that. Medication reminders, meal preparation and feeding assistance, light housekeeping and laundry, companionship and emotional support, transportation to appointments, mobility assistance, and salary is based on experience. So for anybody that is looking for a live-in position, this would be, a possibility for you. So, all right. Any questions on hand and nail care? Okay, we're going to move on into making an occupied bed. We're going to get through this very quickly. And then we're going to jump right into blood pressure. Okay, making an occupied bed is not difficult. You're going to change the sheets with the patient remaining in bed. The way that we do that is the bottom sheet just gets changed to half of the bed at a time. That's all we have to really know about that. I'll show you how. It's not nearly as hard as people think it is. I actually kind of look at it as like a Houdini trick, presto changeo, the sheets are clean. Fun trick to do at parties if you're looking for a little extra money, bet somebody that you can change the bed with them in it. It's not a hard skill by any means though, okay? All right, overview is here on page 141. You can see all of the principles involved. And lucky for us, we know almost all of them. We know to follow the care plan. We know every skill starts with an opening. Every opening starts with a knock. We know to evaluate if we need gloves. How would we know if we need gloves? If we're going to touch body fluids.
Broken skin.
Yep, broken skin or personal skin. Okay. So if your patient is fully dressed and holding on to all of their own body fluids like a champ, would you need gloves for this?
No.
No. So for the test, your patient is fully dressed and holding on to all of their own body fluids. You will be a patient for this, right? But that doesn't mean that every situation you find yourself in out there won't require gloves. If we're working with an incontinent patient, need gloves. I'm sorry, hold on. The penguins are marching. Yes.
That's every time.
Oh,
Literally.
I don't want to go that far. I know, it's cold in here. It's so much colder on this side of the room. I need to flip this. It's not nearly as cold over here. All right. So every skill starts with the opening. Every opening starts with a knock. We figure out if we need gloves. We're going to uncover this patient. Hold on one second. Leave that up, Jake. Hold on one second, Tasha. We're going to uncover this patient, which means their knees are exposed. What do I need?
Privacy blanket.
Privacy blanket. This is going to require linens, sheets. So can I hold them against my uniform?
No.
No. We're going to do the closing like we do every other skill, the closing. Every skill ends the same way. What we haven't learned yet, though, is a whole nother principle called scoot and roll. And that's what we're going to focus on right now. Tasha says, I noticed you did not rub the hand with the cloth, just squeeze water over the hand. Is this because the skin is very thin, so we should never rub the hands with a cloth? Can we if the hand is extra dirty? Okay, so Tasha, when you're watching this video, so what you're referring to is actually the rinsing. Okay, when I washed the hand, I took the washcloth, wrung it out, put some soap on the washcloth, and then I washed each surface. I went down and then did the palm of the hand as well, got in between the fingers. We are using some friction when we do that, okay, because we are rubbing. Now, if their skin is super fragile, be gentle with that. Then we just held the hand over the basin and squeezed water over it to rinse it. And that's kind of like you at the sink. when you're rinsing your hands under running water, you're just, you're just rinsing the hands. You can use the washcloth and use some friction on it, but you shouldn't need to because this soap isn't sudsy. Just a simple rinse. You can dunk the hand if you want. Doesn't matter. Doesn't matter. But for washing, yeah, you should use a little bit of friction, just a little bit though. Remember that if your patient's skin is very thin or fragile, you don't want to tear it. If the patient's skin is extra dirty, I'm probably going to ask the nurse if I can get them to the bathroom in some way and wash their hands under running water. Remember, you've always got that option. Talk to the nurse. Say, hey, have you seen his hands? A basin isn't going to cut it. And the nurse may say, oh, I didn't know. Let me go take a look. Let's figure something out. Good? Good. So remember that when you're looking at these skills, your brain might come up with worst case scenario for the care plan that you're looking at, right? So like you, Tasha, you're thinking, what if the hands are extra dirty? Well, in that case, it probably isn't going to be on the care plan to do this hand and nail care. I wouldn't want you to soak a patient's hand in dirty water. So as the nurse, it's my job to come up with plan B or C or D. Okay. So remember that care is going to be planned just for that patient, not everybody. Does that make sense? I don't think I'm explaining that right. So I look at you, okay? What's your name? Alani. So Alani is young, she's fit, she's sweet, right? So, but you're only one catastrophic situation away from having to need healthcare. So what if you get into a car accident on the way home? Let's hope you don't. But what if you did, right? And you needed healthcare. Well, as the nurse, I'm going to plan your healthcare. And I'm probably not going to have hand and nail care on there because it's temporary health care. You're only here for a couple of days while we set your leg. You're going to go home, take care of your own hands. I'm not worried about it. Hand and nail care is not on your care plan. Now, my grandmother, however, completely different story. So she's receiving long-term care. I would have hand and nail care on her care plan. And it would be specific to her needs. So when we're thinking about care plans and we have questions, we have to remember that those questions are always going to be answered by the care plan itself. And not every care plan is going to have hand and nail care. Not every care plan, not every patient is going to require that you change sheets with them in the bed. Not every anything is going to require everything. Does that make sense? So if you have a question, if you're like, hey, this person's skin is like super, super thin. Should I be doing this? Who should you be talking to? The nurse. That's right. That's right. Communicate with the nurse. Does that make sense to everybody? Yeah. Care has to be individualized. There is no one size fits all for anything in healthcare. Nothing. Because we're all different. We're different ages. We're different creatures. We have different health conditions. We're in different places. Everything is different. What I'm trying to teach you are principles that you can apply to different situations that you find yourself in. Okay, good. Good. All right. So not much to learn here. If you look on page 142, we have our step-by-step instructions. At the top of the page is our care plan. Bottom of the page is our supplies. In between tells us how to do this particular skill. So if we look at the care plan, it says change the top sheet, bottom sheet, and pillowcase while the resident remains in bed. You will not have to do this for every patient. If your patient can get out of bed, Don't change the sheets with them in bed. So if the patient, even patients that are bedbound, are often put on a shower stretcher and taken to the shower room to be showered once or twice a week. We have a special stretcher that's made out of PVC with that blue mesh lounge chair material, right, on it, that we put patients onto, take them to the shower room and shower them. The stretcher goes right into the shower. Well, if a bedbound patient is not in bed, that's a great time to change sheets. So if somebody's got the patient in the shower room and you see the bed is unmade, you should probably think to yourself, hey, I should probably change the sheets. Let me take care of that while nobody's in it. If the patient is ambulatory, gets up and walks anywhere they want to walk, well, when they're out of the bed, that's a good time to change sheets. We should only be doing this if the patient is unable to get up and the sheets are soiled. So this is like rare. You shouldn't be doing this all the time. Make sense? Good. I can change a bed with nobody in it in less than 2 minutes. I can change this entire bed if nobody is in there in less than 2 minutes. Easy, easy. If somebody's in there, it takes me about 7. That's a whole lot longer. I can make 3 beds in the time it takes me to make 1 with somebody in it. So time management, I'm going to try to make beds when nobody's in it. But there are situations where we have to know how to do this. What if the sheets are soiled? We can't leave somebody in a wet bed. What if the sheets haven't been changed in 3 days and the patient can't get up? You know, there's a lot of what ifs that would, you know, require us to change the sheets with somebody in it. So we have to know how. But I want you to remember that if you're ever coming across a bed with nobody in it, think to yourself, do those sheets need to be changed?
My question, actually, the assumption, is it okay to assume such thing? Like, let's say you have 3 CNAs, 2 guys are showering the patient, you're standing there. You're okay to assume that you could just change while the patient's not there?
Sure.
Okay.
Well, remember care plans, right? Care plans are going to play a part in this. But I cannot, as a nurse, I cannot conceive of any situation ever where I would be upset that a CNA changed a bed. Can't think of any situation. And one of the reasons is, do you guys know the feeling when you get into bed at night and the sheets are clean?
Yeah.
You know, they're crisp, they're clean. You always sleep so much better, right? It's a feeling I can't explain, but it's real, right? It makes you feel better. So as a nurse, personally, so here's the thing, guys. If you are sick, you want any comfort you can get, right? Any comfort. If you are stuck in bed full time, those sheets are going to get awfully stale pretty quick. And can you imagine being in bed for like you may only change your sheets at home once a week, if even that often, right? And when you get new sheets, oh, they feel so good, right? But you're not in that bed all the time. Can you imagine being in bed all the time? That week-old sheet is going to feel really gross after a full week. So a question I get asked a lot in a clinical setting is, how often should I be changing these sheets? There's nothing in policy and procedure. There's nothing in the care plan. I mean, this guy's been here 2 weeks. Nobody's changed the sheets. Change the sheets. Okay. If you want, you can come to me and ask me. I'm going to tell you, yeah, change the sheets. But this is one of those things that if you've got a couple minutes, it makes the patient feel great. And I can't think of a single reason why sheets shouldn't be changed. I'm sorry. Let me back up. There is one. Oh, there is one. There is one. But it's mostly in the ER. Mostly in the ER. Sometimes we have to know how tall people are for medication computations, right? So we have to know how tall they are and how much they weigh to determine their mass. Some medications are the dosages are calculated based on mass. Okay, so there are some situations where I have to know how tall somebody is. This is generally done in the ER or when a patient first comes in. If the patient can't stand up for me to measure them, and they can't tell me how tall they are, and I don't trust people because people lie, I will take my pen and I will draw a line at the top of their head on the sheet. And at the very bottom of the sheet, I'll kind of get them stretched out and I will draw a line at their feet, at their heel, where their heel touches the bed. And then I will measure the space between, and that tells me how tall my patient is. So if you are changing sheets and you notice marks on the sheet, you might want to check with the nurse, hey, are you measuring the patient? Did you get the measurement? Okay. That's the only situation that I can come up with. And I'm racking my brain here. Okay. It's the only situation I could come up with with a nurse being upset that you change the sheets. But it's not a big deal because I can put markings and remeasure. Okay. It's not that big of a deal. Good. Good. All right. So let's go back to our care plan. Change the top sheet, bottom sheet, and pillowcase while the resident remains in bed. But it goes on. And the rest of it is important for the test. It tells us the resident can roll and move as directed, but cannot get out of bed. That means that you are going to be the patient for this. You can be told to roll over. You can be asked to scoot toward me. You can move as directed. You just can't, I just can't ask you, hey, can you get out of bed so I can change bed? Remember that the evaluators have to follow these care plans too. It then tells us that a draw sheet, bedspread, or blanket is not required, or underpad is not required for this skill. So all we're changing is top sheet, bottom sheet, pillowcase. That's it. We're not putting a blanket on the bed, not putting a bedspread on the bed. We're not putting an underpad under them. We're making this super, super easy. Top sheet, bottom sheet, pillowcase, period. Now, if you look on the next page, what is that? No, that facing page, that one. What page is that one?
142.
Okay, so 143. At the top of the second column in 143 is how to put other things on the bed, whether it's a draw sheet or a chucks under the patient or anything like that. A draw sheet is a top sheet, flat sheet, and it's folded in half lengthwise. Okay, so we take basically we want it as long as we can. So we fold it in half so it stays as long as possible. And we put it on the bed underneath the patient. So we don't put it this way. Even though we folded it this way, we put it on the bed this way so that the edges are hanging off. And the folded edge goes under their shoulders. The part where the two pieces, fold one on top of each other goes under their legs. And now I can use it as a sling to move the patient toward me or up in bed. That's a draw sheet. And you can see that at the top of page 143. It talks to you about draw sheets. I have a whole lesson on them in the online course as well. All right, so are we using a draw sheet?
No.
Are we putting a chucks under them?
No.
Bedspread? Blanket?
No.
Why? Thank you. Awesome job. All right, so we've learned linen rules, right? Linen rules, we learned most of them. They're repeats. Linens can't touch your uniform. You have to have clean hands to get your linens. Don't snap or shake them. And anything you take but don't use has to be discarded. We know all that. But we did skip 2 linen rules. So we're going to go back and talk about those. We're also going to learn scoot and roll. So one of these rules is clean rolls toward me dirty rolls away. Clean rolls toward me, dirty rolls away. And what that does for us is it helps prevent what we call gross contamination. Gross doesn't mean like, ew, gross. It means obvious. Okay, gross contamination means obvious. So let me show you how this works. So we've got a sheet on the bed. Okay, sheet on the bed. We got a patient on the sheet. So far, so good. Now, if I need to change this sheet without this patient getting out of bed, if I've got to leave the patient there, then I've got to do it in a way where the stuff on the top of this sheet doesn't automatically get on this sheet. Now, I'm not too worried about it because the person that made this stuff is still in the bed. You guys get that? That as soon as I change this sheet, the person is going to contaminate the sheet. So I'm not too terribly worried about this, but I want to do this in such a way that it minimizes overt contamination right away. So the way that we do this, if I have a patient, and I'm going to do this on this side so you guys can see it. If I have a patient in the bed and I need to change a sheet, I'm going to be standing over here on this side. Now, I know I'm over here right now, but I'm doing this so you can see, okay? So I'm going to take this sheet. Now, remember, I'm standing here. This is me right here. I'm going to take this sheet and roll it away from me toward the patient, okay? Good. So clean rolls toward me, dirty rolls away from me. And when I roll it away from me, the part of the sheet the patient was laying on is now rolled inside this roll. Not on the outside, it's on the inside of this roll. Let me do that again. Contaminated, roll it away from me. That contamination is on the inside of the sheet.
We have him roll over first.
We're going to get there. Hold on. I'm just talking about the sheet right now. Okay. So we've rolled it toward the patient and we're going to tuck it underneath them. I'm going to take the clean sheet, stretch it out, and the clean rolls toward me. So I'm going to roll the clean sheet. So now the underside of this sheet and the underside of this sheet are all that's touching. So I'm going to put this clean roll underneath the dirty one. I'll have my patient roll over, and I'm going to take that dirty sheet off of the bed and unroll the clean. And now my patient is in a clean bed. Okay. Clean rolls toward me. Dirty rolls away. Good? Questions? Okay. While we're doing this, we don't let anything touch the floor. Not clean, not dirty. Remember we talked about dirty washcloths don't go on the floor, dirty towels don't go on the floor? Same thing here. Dirty sheets don't go on the floor. Now, I have to point that out because when we're at home, where do we put the sheets that come off the bed? On the floor. Yeah. You take the sheets off, throw them on the floor, change the sheets, and then you bundle them up, take them to the laundry room. We do this all the time. We can't do it in a clinical setting. Nothing goes on the floor, not clean, not dirty. That means we have to have a place to put our dirty sheets when they come off the bed. You could put them on the barrier. Remember, like we did earlier, we just kind of carved out a little space for our dirty stuff. You can do that for this too. I don't like to do that because they take up a lot of room and they're probably going to, get in our way. So what we do instead is use somewhere to put these sheets right away. So we take them off the bed, they go somewhere right away. Now, in some places, you'll use a hamper like this. For the test, you're going to probably use a hamper like this, and it'll be right there, right beside the bed. But this isn't normal in a clinical setting. We don't keep dirty things in a patient's room. That hamper's usually in a hallway, like down the hallway. So you're not going to like leave the room, go out. That's too much work. So we have to have a place in the room to put this stuff. So if we don't have a hamper, you could put a Chucks on the floor. It's okay. You can do that. I prefer not to, but you can. It's okay. Just like we put a Chucks on the table to make a barrier, you can put one on the floor and put your dirty stuff on the floor. That's okay. A better way, though, is to go directly to your utility room and get a soiled linen bag. These bags are, they kind of look like trash bags. They're light blue. They're stamped with soiled linen on them. Do you guys know what Tide Pods are? Right? You toss them in and the plastic dissolves and it releases the soap, right? We're used to that now. These are the original Tide Pods. These have been around for like 50 years. And the bag itself is the soap. So this whole thing goes right into the washer. Whatever's in the bag is going in the washer. So that means when you're rolling this stuff, if you have dentures or hearing aids or cell phones or earrings, they're going in the washer and you'll probably ruin them. So when you're removing things from the bed, it's your responsibility to make sure that there's no foreign objects in these sheets. Nobody in laundry is going to take this stuff out of the bags and shake them out to make sure there's nothing in them. That's our responsibility. Make sense? Let me tell you a little anecdote about why. I have got to quit talking. Ah, crap. I can't tell you. We're really late. Okay. So get a soiled utility bag. Put the linens directly in soiled utility. Good? Good? All right. Okay. This is a soiled utility room. This is often where you're going to find your soiled linen bags, but it's also where you're going to take your soiled linens when you're done bagging them up. It's a special room. Only dirty things go in soiled utility, period. Nothing clean can go in there. Don't take anything clean in there ever. It's a dirty room. Just like nothing dirty can go into clean utility. So if you've got a bag of dirty linens, don't go into a clean utility room to grab a supply you need with your dirty linens. Clean stays clean, dirty stays dirty. Good? Linens, we already know you use it or you lose it. If you take too much of something, it goes in dirty linen. Don't save it for later. Good? All right, so now we're going to learn scoot and roll. This is a way of keeping your patient safe while they remain in bed. And the biggest thing you have to remember with scoot and roll is that you can't rely on side rails to keep your patients safe. In fact, most settings don't even have side rails. Not even there. Can't use them if they're not there.
It's against the law.
So it is. It's considered a restraint. Side rails are a restraint. So it's like a crib with a baby. You put a baby in a crib to keep them confined. You put side rails up, that's what you're doing. You're keeping your patient confined, and it can actually result in their death. Side rails kill several hundred patients a year. Very, very serious. And the thing is, we don't need them. The safest place for your patient is in the middle of the bed. Just make sure they're in the middle of the bed at all times. So if we're going to turn a patient over, I can't just turn them over. They're going to be too close to the edge of the bed. So I'm going to have her scoot toward me and then turn her. When I do that, after the turn, she's in the middle of the bed. You do this yourself without even thinking about it. When you go home tonight, I want you to lay down in your bed, and then I want you to turn. Now, when you turn, you're going to, and I want you to pay attention to how you turn. You don't just roll, right? If this guy, if I want him to turn, he rolls, right? But that's not what we do. When we turn, we actually scoot and turn at the same time. So you stay in the same space, but facing a different direction. You shift your butt when you roll on your side. And that keeps you safely in your space. You don't realize you do it, but you do. Now, when we're working with patients, we do this in 2 steps, where you can do it in 1 because it's your body. When we're doing it with patients, we scoot them toward us and then we turn them on their side. And it accomplishes the same thing. Okay? Make sense? But I do want you to lay down in bed and turn and notice what your body does. You shift your butt. You pick it up and move it. That's what we're going to do with them. We're just going to do it in 2 steps. So remember that side rails kill patients. This is what happens. When you put an obstacle in somebody's way and they have to go over it, around it, through it, or under it, it catches part of their body and it can kill them. So this is why side rails are considered a restraint and why we have to have a doctor's order to use them. When we have a doctor's order, the nurse can't even decide to use side rails. The doctor, as a nurse, I have to call up the doctor and tell the doctor, hey, I think we need side rails for this patient. And the doctor's going to ask me why, what steps I've taken, why I think that restraining this patient is a good, I've got to justify it. And then that doctor has to physically come in and eyeball the patient within 4 hours of giving me that order. Can't take my word for it. This is false imprisonment, guys. And let me explain to you how serious this is. This is serious. Seriously serious. There's only 2 types of people that can restrict your freedom of movement once you're an adult. And they're temporary. There's only one that can do it permanently. So the 2 temporary ones are police officers. A police officer can handcuff you. They can restrict your freedom of movement. Law enforcement, not just police. Law enforcement, okay? They can restrict your freedom of movement. They can put you in a jail cell. They can confine you as an adult. But they have to have probable cause. They can't just do it for no reason. They have to have a reason, right? But it's temporary. They can't just throw you in a jail cell, lock you up, and leave you there forever. It's temporary. The other temporary one is a doctor. A doctor can order restraints or side rails. But again, they have to have probable cause. They can't just decide, hey, I don't like you, I'm going to tie you up. Doesn't work that way. And again, it's temporary. The only person that can make long-term confinement of an adult is a judge. That's it. A judge is the only person that can order a long-term confinement of an adult. So as a police officer or a law enforcement person, they lock you up, you get to see a judge. As a doctor, temporary, he gives a restraint order. Anything longer requires a judge. Do you guys see how CNAs can't do this, guys? CNAs were nowhere in that conversation. A nurse can't do this. A nurse is nowhere in that conversation. A doctor, like law enforcement, can make a temporary order for short-term confinement. Anything longer than that requires a competency hearing in front of a judge.
So this is only for side rails that cover like all the sides of the bed, because like I've worked in a facility with.
That's what we're going to talk about now.
Okay.
Yep.
Okay.
Yep. So this is a side rail, something that captures the entire bed. This, when both ends are up, are a side rail. It restricts movement out of the bottom of the bed. This is not a side rail. This is, I know, that's why I've got a slide for it. Yep. I know. Yep. So this is what we call a positioning rail. This does not impact the patient's ability to get out of the bed on their own because it's not restricting the bottom of the bed where their legs swing out. This helps a patient reposition in bed. This is okay. This is not. Good? Yep. All right. It's called a half rail or a positioning rail. And you can see that's acute care, that's long-term care. So the safest place for a patient to be is in the middle of the bed. We call that the safe zone. If they're not in the middle of the bed, you took a wrong turn. Good. Questions? Okay. Turning a patient on their side and using side rails to keep them in bed is an unnecessary risk, and it's not tolerated. There's no reason for it. Can you imagine for a second not being able to move? Be completely dependent on another person, having them turn you over so you're pressed up against side rails, and you're hoping and praying that those side rails don't fail for you to fall on the floor. Can you imagine the mental anguish there? It's unnecessary. Just keep them in the middle of the bed. Good. So we're going to have the patient scoot toward us, and then we will roll them on their side. Oop, nope. Sorry. I don't look. All right. Just make sure your patient's in the middle of the bed. And when you do that, always turn your patients facing away from you. There's two reasons for this. Weight distribution. Gravity tries to pull patients back onto their back. It's where most of our weight is. Gravity will always try to pull them backwards. If you're on the other side of the bed, you're not going to be able to stop that roll. Second reason, no easy way to say this. Do not ever turn somebody so they're eye level with your crotch. You never turn a patient towards you. That's just it. I don't care whether you're male or female. It's still a threat. That patient is dependent. That is a threat. And don't think that sexual assault does not happen in healthcare.
Oh, yes, it does.
It happens way more often than we think. One of the worst cases was in Citrus County back in the 90s.
Mhm.
Google it. Google the young lady in Arizona that was impregnated by a nurse. She was in a persistent vegetative state, gave birth at the facility. Nobody knew she was pregnant. CNA was bathing her. She was moaning. And the CNA went to clean her with pericare, and there's a baby coming out. This happens. Don't turn a patient towards you. All right. So let's learn how to make an occupied bed. We're going to have to, all right. I'm going to have to move some things around. We're not going to be doing blood pressure today. I'm going to push blood pressure off. I'm going to get to the range of motions today. We're going to do this and range of motions. I'm going to move blood pressure until another day, probably closer to the end of the program, but just stay tuned. I'm going to have to move some stuff around. All right. So there's a couple different ways that beds can be adjusted. Head of the bed can go up and down. It might need to be adjusted for safety during a skill, like brushing teeth. You need the head of the bed up, right? Head of the bed up and down. Foot of the bed can go up and down. Entire bed can go up and down. At the end of the skill, I don't care about the head and the foot, whatever the patient wants, whatever's comfortable for them. They might want to sit up and watch TV. They might want to lay down and take a nap. I don't care. But the entire bed, I do. Because if the entire bed is higher than the patient expects it to be when they get out of bed, they're going to end up falling because the floor is not where they left it. This is important because for this skill, you probably will want to raise the bed. You're changing the sheets, and that requires a lot of bending for most of you. So you may want to raise the bed to a comfortable working position for you during this skill. But if you forget to put it back down at the end of the skill, it is an automatic fail. Automatic fail. Why? Because of the patient. That's right. It's all about the It's not about the fact that you forgot a step. It's the fact that you put the patient at risk. And if you do it during the test, you'll probably do it in a clinical setting too. Good? So when we turn a patient, when we're changing the sheet, you don't want to put the patient on a bare mattress. Always make sure there's something under them. Dirty sheet, clean sheet, something. Don't take the sheet completely off of the bed, leaving them on a bare mattress, and then put the new sheet on. That's why we change this a half at a time. Good? There was a video, they took it down, thankfully. But there was another school that put a video up that took the sheet completely off of the bed and left the patient on a bare mattress as an instructional video. No, don't do that. All right, so we're going to change it a half at a time. We're going to use that clean rolls toward me, dirty rolls away. So if you kind of, I just moved the patient up so you could kind of see underneath the patient what this looks like. Okay, the patient isn't actually going to levitate for you. If they did, it would make this job a whole lot easier. But we haven't figured out how to do that yet. So I just kind of moved the graphic up so you could see under the patient what that's going to look like. You should have the dirty sheet rolled in one direction, the clean sheet rolled in the other, and they should be laying one on top of each other with the patient right on top.
And more like SNFs or like skilled nursing, do they use the Hoyer lift at all to lift patients?
Again, that's going to be based on the care plan for that patient. So yes, some places will have mechanical lifts. Yes, but it requires two caregivers, one to work the mechanical lift and the other to pay attention to the patient. Yep. Yeah. But yes, and like I said earlier, anytime the patient's out of bed is a great time to change the sheets. So yes, if we've got a order for a Hoyer lift and you're getting the patient out of bed and into a chair, that's the time to change the sheets. Okay, you're welcome. So once we get the clean sheet on the bed, completely on the bed, make sure all four corners are secured to the mattress. So it just makes sense. But it's a checkpoint, which makes me wonder who's not securing the corners to the mattress. If it's a checkpoint, it means that other people have not done that step. That's why they detailed that it has to be done. Minimize wrinkles under the patient. We're going to put a top sheet on and we're going to make hospital corners. They do not have to be pretty. They do not have to be perfect. All we're trying to do is get the corners of the sheets under the mattress.
So we don't use any like fitted sheets because you can't roll it.
So the fitted sheet, yes, you will use a fitted sheet on the bottom. So you're going to, and you'll see, it's actually easier than you think. It is. So we're going to, I'm going to turn the patient away from me. I'm going to undo the fitted sheets on the corners that I'm closest to, and we're going to roll that toward the patient. And believe it or not, it does roll, even though it's fitted, because it's not attached anymore. So we're going to roll it toward the patient, tuck it under them as far as we can. I'm going to take the clean sheet, stretch it out, and I'm going to attach the corners. So the corners are what's going to kind of hold the sheet in place while I roll it toward me. Okay, good question. All right, once we get that top sheet on and we've got the corners under the mattress, hopefully with hospital corners, I'm going to show you how, but just get the corners under the mattress. Loosen the toes. Because when you put those corners underneath the mattress, it's going to make the end of that sheet press the feet down. It puts pressure. We don't want those feet to be pressed down. So we're going to loosen that sheet over the toes. Now, the reason you want hospital, so some people are like, well, why would you even do hospital corners if it's going to push the feet down? It's going to smush the feet. The reason is that nothing can touch the floor. Remember our principle there? Nothing can touch the floor. It becomes a tripping hazard, but it's also back in the old days, we didn't have AC. We had windows open. There were insects. So it just provided another avenue for insects to crawl up. I would not have done well. We're going to change pillowcase, limit the amount of time the patient doesn't have a pillow. So we do this last. Leave the pillow in place. And yes, I know there's a dirty pillowcase on a clean sheet. I get it. I know. The patient is still in the bed. The patient is dirtier than that pillowcase is. Don't stress out. Leave the pillow on the bed while you're changing that bottom sheet and putting the top sheet on. Don't let that patient just have to lay there without a pillow. It's uncomfortable. We're going to change the pillowcase, but you're not going to change it the way you do at home. At home, you probably put that pillow underneath your chin and shimmy that pillowcase up. That pillow has been drooled on, sneezed on, coughed on. You want that up near your holes? Probably not. So we don't put the pillow under our chin. I'm going to show you how to do this. You're going to make that pillowcase like a nightcap, scrunch it all up, put it on top of the pillow, and pull the sides down. That way it never has to go up next to you. Okay? You're looking at me funny. I'll show you how. All right, limit the amount of time the pillow is not under the patient. So remember that this is your instruction manual for your patient, your care plan. It's only for this patient, though. It doesn't work for that one or that one. Those two people can probably get out of bed. Good. Remember, your care plan is specific to this one patient and their specific needs. So if they have a Hoyer lift order, we're going to use a Hoyer lift. If they can get out of bed, we'll change the sheets when nobody's in it. Every situation is going to be different. We're going to take our clues from the care plan.
So on this care plan, it says resident can roll and move as directed. So could I ask them to sit up?
Sure. It says they can roll and move as directed. You could, but it's not going to benefit you.
For the changing the pillowcase? Or
Yeah,
do you have to do it under their head?
Yeah. Well, no, you're going to take the pillow completely away. You could ask them to sit up, to take the pillow away. That's fine. But it's just, there's really no benefit to it. You could ask, but there's no benefit to it. It takes more energy to sit up than it does just to lay there without a pillow. We're going to talk about energy conservation a little bit later in the program, and you'll understand why I'm saying that. All right, Jake, can you put making an occupied bed up for me, please?
Hello.
Good morning, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Wonderful. I'd like to change your sheets. Is that okay?
Yes.
Let me close your curtain, wash my hands, get my supplies, and I'll be right back. After washing my hands, I'll get the supplies I need for this skill. So we're going to start with a barrier, putting it on the overbed table. This gives us a clean place to put our clean supplies. And then to make a bed, we're going to need a pillowcase, a top sheet, a bottom sheet, and a privacy blanket. We're going to start with the bottom sheet. So I'm going to place a privacy blanket over you. This is going to help keep you warm and provide some privacy as we do this skill. So I'll spread this out, being careful not to shake it or snap it, and lay it in place. I'm going to pull your top sheet all the way down, and we'll remove it from the bed. Wrapping it in a ball, so that the trailing edges don't contaminate other surfaces. We're going to lay this on an unused part of the barrier on the table. Mr. Jones, can you scoot your whole body toward me? And then I'm going to ask you to roll to that side so you're in the middle of the bed. Thank you. We're going to remove the sheet from the top and the bottom of the bed, and we'll roll this toward the patient. Dirty always rolls toward the patient. And we're going to tuck this in under the patient's body, all along the length of their body. Now we'll take the clean sheet, unfold it, and spread it out on the mattress, being careful not to shake it or snap it or let it touch the floor. We'll secure the corners. And then we'll take the clean sheet and roll it toward us to minimize wrinkles. And then we're going to lift the bottom sheet and tuck this clean sheet underneath the bottom sheet, all along the length of the body. So we'll roll it toward us. And then tuck it underneath the soiled sheet. You want to minimize the wrinkles that are under the patient. All right, Mr. Jones, can you come back onto your back and scoot to the middle? You'll feel a big roll. Okay, I'm going to go to the other side of the bed now. Can you scoot toward me, please? And then roll on your side so you're facing that direction. Thank you. We're going to remove the bottom sheet from the bed, rolling it in a ball. And then we'll place this with our other soiled items on the overbed table. We'll stretch out the clean sheet. Attach the corners. Minimizing the wrinkles underneath the patient. Okay, Mr. Jones, can you come back onto your back and scoot to the middle, please? Okay. Now we'll put the top sheet on. We want to open this up and spread it out, being careful not to snap it or shake it. We'll lay this over the patient. Making sure that there's an equal amount of sheet on each side of the bed. And then we're going to tuck the sheet under the mattress. So we'll lift the mattress and pull the sheet so that it's flat under the mattress. We're going to come down about a foot from the end of the bed, pick it straight up. You'll see a triangle here, and tuck in the bottom. We're going to lift the mattress from below, tuck the sheet so that it's flat under the mattress. Come down about a foot from the end of the bed. Pick the top flap straight up. You'll see a triangle. Tuck everything else in. We're going to loosen this over the toes. And now I can remove your privacy blanket. I'm going to roll this into a ball and place it with our other dirty items. Mr. Jones, can I take your pillow? I'll bring it right back. We'll remove the pillowcase by holding the pillow and sliding the pillowcase down. We're going to place this with our other soiled items and put the pillow on the table. We'll take the pillowcase, scrunch it all the way up to the corners, and the tag side of the pillow will go into the pillowcase. So we'll stand it up, slide the pillowcase over the pillow, hold the whole pillow and pillowcase, and slide the sides down. The opening of the pillowcase is going to face away from the door. Mr. Jones, can you lift your head up for me? Thank you very much. Are you comfortable?
Yes.
Let me dispose of my supplies, and I'll be right back. These are going to go into dirty linen. And then we'll dispose of our barrier. We'll place our table back and make sure our environment is clean. All right, Mr. Jones, is there anything else I can help you with?
No, thank you.
Are you comfortable?
Yes.
Would you like a magazine before I go?
No, thank you.
Okay, your call light is right here. If you need anything, just press that red button. We'll be happy to help you.
Thank you.
Bed is in the low position. Environment is clean. I'm going to go wash my hands. After washing my hands, I'll review the care plan, make any corrections, and tell the evaluator my skill is done.
All right. Any questions? Pretty easy, right?
Mhm.
Not nearly as hard as people think it is. All right, so we're going to move on. I'm going to show you 2 range of motions. We're going to push blood pressure off to another day. If you go to page 76, this is the skill we did not get to last class. And thankfully for us, it's incredibly easy. So if you look at the kind of the overview, all of the principles involved, they're all spelled out for us here. We know to follow the care plan. We know to do the opening. We're going to evaluate if we need gloves, and we know how to do the closing. There's nothing new to learn here. But we do have to learn a little bit about range of motion. So if you look down here, this is our test-specific information. Somebody with your level of experience should be able to do this within 4 minutes. This is going to be done on another live testing student. So that means that you guys will be a patient for somebody doing this skill. That person will be positioned in bed at the beginning of the skill. Charting is not required. So Jake, yeah, go ahead and advance for me. So let's take a look at the care plan at the top of page 77. Your care plan is here. It says provide the following range of motion exercise to the resident's left shoulder. Flexion extension and abduction adduction. Now, before you get all tangled up in all those big words, let's discuss what they are. Okay. Flexion extension is an up-down movement. Abduction adduction is a side-to-side movement. And rotation is an around movement. So I'm going to show you all of those in just a second. It tells us to provide 3 repetitions of each exercise, and the resident is not able to help with the exercises. No supplies. This is an easy skill. Not much to it. But go ahead. We have to understand a little bit about physical therapy, okay? A lot of times CNAs look at range of motion care plans like this one. It says perform range of motion, and we automatically think of physical therapy. Physical therapy is there to help improve function, to regain something, to make it better. But physical therapists have to go to school for a doctorate degree. That's about 12 years of schooling. How long are we here?
4 weeks.
That's not us. Not us. CNAs are not working on injured or weak extremities. It's not our job. That's physical therapy. We are working on healthy extremities to keep them healthy while the patient is undergoing other treatment. Imagine for a second this person laying in bed. They've got something going on. I don't know what, but they're stuck in bed. If we leave them stuck in bed for an extended period of time, they're going to get weak. And by the time they overcome whatever it is that made them stuck in bed, they may be stuck in bed for the rest of their life now because their muscles atrophied, shrunk, got weaker. So our job is to help maintain their current level of function. Does that make sense? So CNAs do not do pain at all. If your patient winces, grimaces, says ow, starts to resist, anything like that, we go below the ow for the next one. So if we get to here and the patient says ow, then the next one will go below the ow. We're not there to inflict pain. We're not there to make anything better. But what do I need to do with that little bit of information I just gained? Tell the nurse. Good? Make sense? Okay, so this isn't hard. Go ahead. So a great way to remember this is that CNAs do exercises to retain function, keep what's already there. Physical therapy and their assistants will do exercises to regain function, get something back. You guys understand your role? Go ahead. All right. So there's two types of range of motion. There's active and passive. Active range of motion means a patient does it themselves. We're just there to help facilitate. So everybody up. I am going to ask you to extend your left hand above your head like you're asking a question. Extend your left hand. Get that elbow nice and straight. Reach for the sky. Bring it all the way up. Very good. All right, bring it all the way down in front of you. In front of you. All right, all the way to your side. Now let's do it again. All the way up and all the way back down in front of you. One more. One more. All the way up and all the way back down. Okay. Now we're going to take that arm out to the side like you're making a snow angel. So we're going to go out to the side, all the way up, get that hand all the way up, and bring it back down to the side, all the way down to your side. Let's do that again. All the way up and all the way back down. Oh, one more. Come on. All the way up and all the way back down. Good job. Have a seat. You just did range of motion, but you did active range of motion. You did the work. I just told you what to do, and I made sure you were doing it properly. The first exercise, go ahead, Jake. The first exercise we did was flexion extension. I actually told you to extend your arm above your head like you were asking a question, but I gave you a real world example that you were familiar with. That way you knew exactly what that motion should look like. If I just said, okay, do flexion extension, you guys all would have sat there and looked at me. When you're working with patients, they don't know what these words are either. So you want to give them real world examples so that they know what these exercises are going to be. That way they don't resist because they're afraid it's going to hurt. Good? Good? All right. So go ahead, Jake. So we're always going to support from below when we're lifting. So active range of motion was what you guys just did. Passive range of motion means I'm going to do the work. I'm going to lift the extremity. And when I do that, I want to lift from below. We're not the claw machine at Walmart. Don't do that. Go ahead. We're going to move slowly and smoothly and always return back to start. And I had you guys do that. When I asked you to bring your arm up like you were asking a question, I told you all the way back down to your side, right? This is not a full range of motion. We have to end where we started. Go ahead. So we're going to return all the way to the start position. Flexion extension is always an up-down motion. Doesn't matter what body part, it's always up-down. Go ahead. Abduction, adduction is always side to side. Go ahead. And rotation is always around. Good. We don't do all exercises on all body parts. In fact, some joints don't move in this direction at all. An elbow is a hinge joint. It only does this. If you get an elbow to do anything other than this, you broke it. Okay? So we have to pay attention to our care plan. Our care plan is our recipe. It's going to tell us what body parts, what exercises, and how many repetitions. We're going to follow that. Good? We want to ask about pain and discomfort as we do this. So this is our care plan for this skill. Provide the following range of motion to the patient's left shoulder. Flexion, extension, up, down, and abduction, adduction, side to side. Provide 3 repetitions, and the patient is not able to help with the exercises. Questions? Okay, now, real quick before I show you this, I know I'm going to keep you 2 minutes, guys. I'm going to keep you, well, Jake, go ahead and throw the video up for shoulder. I was going to try to throw elbow and wrist in, but I'm out of time. It'll be class 2. Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Wonderful. I need to do some range of motion exercises on your left shoulder. Is that okay?
Yes.
Let me close your privacy curtain and wash my hands. I'll be right back. Okay, Mr. Jones, the first exercise I'm going to do is bring your arm above your head and back down to the bed like you're asking a question. I'll do all the work. All you have to do is let me know if there's any pain or discomfort as we do this, okay?
Okay.
So we're going to bring your arm all the way up, supporting at both joints. Slowly and smoothly, all the way back to start. Here's 1. We're going to do that 2 more times. Up, still okay?
Yes.
Back to the bed, and 1 more. Up, and back to the bed. Okay. The next exercise we're going to do is bring your arm out and back in like you're making a snow angel. Okay?
Okay.
So I'm going to support at 2 joints. We're going to go all the way up and all the way back to start. Feel okay?
Yes.
All the way up and all the way back to start. Still okay?
Yes.
1 more. All the way up and all the way back to start. Good?
Yes, ma'am.
Are you comfortable?
Yes, ma'am.
Would you like a magazine before I go?
No, thank you.
Your environment is clean. Bed is in the low position. Let me give you your call light. Here's your call light. If you need anything at all, just press that red button. We'll be happy to help.
Thank you.
I'm going to open your curtain and go wash my hands. After washing my hands, I'll review the care plan, think about my skill, make any corrections, and then tell the evaluator my skill is done.
Okay. 2 seconds, and then you can go. Review sheets that were handed out will cover most of today. We did not get to blood pressure, so please remember that blood pressure will be on the review sheet. We have not covered that yet. Homework for tonight is going to be chapter 4. It is complex. I want you to pay attention to the changes of aging with each body system. We're going to review it in class on Wednesday. Okay? So read chapter 4, take the test on page 184 and grade it. And I will see you guys on Wednesday. Thank you guys so much. Game show tomorrow. Thank you. Game show tomorrow at 11 a.m. Hope to see you there. Those of you joining us virtually, thank you so much for tuning in. We hope to see you tomorrow for the game show, and come back on Wednesday for class 4 of our current session, and we will work blood pressure in somewhere in the future. All right, until next time, happy caregiving. Bye.